format, no? I wanted to remind all of you that if you are going to send me clarifications and questions regarding your handouts or things that you want to get clarify in the handouts, please, no, take a screen cap of the relevant, take a screenshot of the relevant pages, so that when you send it to Doc Broly, which is what we put on our infographic, please put the relevant screen cap para he knows which page, so he doesn't have to scroll through. Mas mabilis, the more we follow the instructions in all of the infographic, the faster we can process your request or process your inquiry. No, so just follow that instruction. Are we live streaming now? Hello, everybody. Hi, everybody. We're not there yet. I will play the video again for everybody as soon 5 minutes before. Hold on. Kamusta, everybody? I know we are supposed to have a the midnight snack contest for my sections. MG Rocky, for my sections. Yes, we're going to have the dinner break on the midnight snack contest. Give me a minute. I will just it was a busy day. So I will give you the mechanics of our midnight snack contest kasi katatapos lang natin ng the breakfast club. Okay? All right. Yeah, today was my pwede ba mag-chismis? Kumusta kayo? Kumusta ang IM? Parang ang bilis, parang pumikit lang ako IM na. Diba? Kumusta ang IM para sa inyo? Okay. IM is a subject that people, this is the typical victim. Ito yung typical victim, no, Ian, ng yung mga sinasabi nilang study smart, not study hard. Kasi parang feeling nila, ay hindi, kung hindi ko makakover lahat, ito lang yung cover ko. Guys, there's no substitute for brute force, okay? Yes, there are probably some subjects that you will prioritize, but that doesn't mean you don't read all of it, okay? You read all, find your weakest, and you read that twice. That's studying smart, okay? Don't treat, not all topics are created equal, but all topics must be covered. Okay, so let's get that clear, okay? Hindi yung mga, I'm just going to study what I think is patok. That is the shortest way to not do well in the exam, okay? Because we don't think the same way as the Board of Medicine people do, okay? Let's see, we have 4 more minutes. Sige, pagdating ng in the last 4 minutes before we officially start, I'm going to play our video again. I like those videos. I don't know if you saw me there, but I was singing, wasn't I, Ian? Wasn't I? I was singing.
Of course, yeah. Doc. We recorded that, Doc.
Yes, they keep making me sing. I keep telling them not to do that. Okay. The other one, but I think the one that we played during the breakfast with MG was one where I danced. I don't know why, but MM didn't put it in. I don't know. But, okay. Gusto ko lang paalala sa inyo. Aminin nyo dito, kayong mga doktor kayo. Sino dito ang dance troupe? Nung high school, nung college, yung mga taga-UP, UST, yung mga sumayaw. May talent tayo, mga kaibigan. Meron tayong fallback plan. Okay? Diba? Nakikita nyo yung mga, pwede tayong mag-TikTok influencer. Pero first, get the license. Okay? After nyo mag-license, kung sabihin nyo, I wanna take a break. Gusto ko mag-content creator. Ala, sige! Sige, doon ka sa TikTok. Pero right now, get that license first. Diba, Doc Ian? Is that right?
Aral muna, guys. Once you get that license, then do whatever you want.
That's true, Because, diba, nothing beats, this is just purely a self-centered point of view. No? Nothing beats substance. Diba? Kahit gaano ka kagwapo, pag parang halata ng tao na superficial yung sinasabi mo, na you only know a little bit, parang, ang boba niya. Parang may gano'n. May gano'n, so cute to look at. Parang salita na siya, parang, so cute to look at. Ang ganda lang. Diba? So, make sure you have substance. So, get your license. Make sure that you know which points are interesting so you can pound on it. And then after that, you can talk with credibility when you actually become a content creator. Ano mo, grabe na, I think, parang yung kids ngayon in my daughter's school, ano oras na ba? dakdakan ng dakdak. Yeah. Ano yun, in my daughter's school, tinanong sila, diba, normally, what do you want to be when you grow up? Ang daming sumagot ng YouTuber. Natakot kaming mga magulang. Kayo, sino gusto mag-YouTuber dito? Or maging influencer? Raise your hands. I'm raising my hand. I want to be an influencer, but nobody wants to be influenced by me. I don't get it.
Ayan, may mga nag-raise ng hands, Doc.
O tara, gawa tayong TikTok, okay? Yan, sige, let's go. Let's go, gawa tayo, ha? Pag natapos na pumunta kayo dito sa akin, tapos magawa tayo ng content.
Mag-mentor kayo pagpasa ninyo.
Oo.
Volunteer kayo.
Yun din, mag-mentor kayo. Tignan niyo muna kung kaya niyo muna mag-influence bago tayo mag-influencer. Alright, I think let's go ahead and play this thing again. This one is I'm sorry. Can I say this? If it's okay? This is my favorite one. This is my favorite send-off video or message video from everyone. I hope you enjoy it. I hope you like it. I hope you get inspired. Okay? Mas maganda yan kaysa kay Sian Lim. Sandali lang.
I close my eyes and I can see a world that's waiting up for me, that I call my own. Through the dark, through the door, through when no one's been before, but it feels like home. They can say it all sounds crazy. They can say I've lost my mind. I don't care, so call me crazy. We can live in a world that we design. 'Cause every night I lie in bed, the brightest colors fill my head. A million dreams are keeping me awake. What the world can be, a vision of the one I see. A million dreams is all it's gonna take. A million dreams for the world we're gonna make.
There's a house we can build, every room inside is filled with things from far away. The special things I compile, each one there to make you smile on a rainy day.
They can say it all sounds crazy. They can say we've lost our minds. I don't care if they call us crazy. Run away to a world that we design. 'Cause every night I lie in bed, the brightest colors fill my head. A million dreams are keeping me awake. I think of what the world could be, a vision of the one I see. A million dreams is all it's gonna take. A million dreams for the world we're gonna make.
However big, however small, let me be part of it all. Share your dreams with me. You may be right, you may be wrong, but say that you'll bring me along to the world you see, to the world I close my eyes to see. I close my eyes to see.
brightest colors fill my head.
A million dreams are keeping me
A
awake.
million dreams, a million dreams. I think of what the world could be, a vision of the one I see. A million dreams is all it's gonna take. A million dreams for the world we're gonna make.
Conquer the world. Tibay ng loob, everyone.
For the world we're gonna make.
This is really my favorite of all the videos. You're going to see more. You're going to see more videos as we go on, syempre. But this is my favorite one so far, no? Wait lang, i-blur natin yung background. Sorry. Hi, everybody. Good evening, everybody. Welcome to our Quizmaster and the Quizmaster and summary lecture for our IM, no? It was a very quick and it was, I hope that you were able to cover as many topics as you are supposed to. If not, don't be bothered by it. There'll be time enough for that. Now, let's begin. I think, Doc Raleigh, are you here? Okay. If Doc Raleigh is ready, floor is yours. Wala pa yata si Doc Raleigh. He'll join us in a while, no? Once again, I'd like to remind all of my section. Yes, our next contest is coming up. Just give me a minute. I'll send the mechanics for it tonight. Okay? Doc Raleigh, floor is yours. We've already started. Okay, while we wait for Doc Broly, kamusta kayong lahat? Kumusta kayong lahat? How was studying for your IM or internal medicine? Did you enjoy it? Where are we here? Sorry, there's a chat. Nag-enjoy ba tayo? Wag kayo, like I told you before, no, wag tayong masyadong magpapanic if we leave some topics behind. There will be enough time for that, no? Do we have any questions so far or any clarifications before we start? Wala pa naman. Doc Raleigh, are you ready for us?
Paunahin mo na muna si Dr. Carl, hindi pa ready yung PowerPoint.
Okay, no problem. Give me a minute, please. Sandali lang po, ha? Okay, so our first speakers, sandali. Okay, so our first speaker, let me share my screen first, no? Okay. Bato sandali. Yan. Okay, so today we're going to have our our internal, bakit ganito to? Sandali. Our internal medicine, wait lang, sorry. Okay, so our internal medicine summary lecture first. We'll begin with, yeah. We will begin with our internal medicine summary lecture. It will be given to us by one of our esteemed colleagues who also studied with us last September 2017, no? Dr. Carl Philip Avilo. is from the Western Visayas State University. Top 3 siya noong September 2017 PLE. He is currently taking his internal medicine residency in PGH, and as of the moment, he is the 2021 top notcher of the Specialty Board of Internal Medicine qualifying exam. On a more personal note, if you want to see a lot of Dr. Carl Avilo, he is an avid YouTuber. Okay, he is, yan yung pinag-usapan natin kanina, the influencer. Make sure that you have credibility and content first. And one of our great examples here is Dr. Carl Avilo. He is content creator of marvelous content on how to study for the boards, how to study, how to organize your head, and how to think like a doctor should. So the floor is yours, Dr. Carl Avilo. Where are we? Here.
Hi, Doc. Good evening. Okay, let me just share my screen. Okay. Wait lang. So good evening, everyone. Welcome to tonight's summary lecture in IM. So the way na gagawin natin tong lecture na to is a little bit different from how the lectures were done in the past few days na napanood niyo yung mga IM lectures. So ang gagawin natin dito, I will just pick the concepts and the topics na frequently lumalabas sa PLE for the past few PLEs, past few years, because these are the topics and the concepts na kailangan nyo talagang ma-master. Okay? So, well, kailangan nyo talagang ma-master lahat. Ideally, kailangan nyo ma-master yung buong handout. Kailangan nyo matapos yung handout, pero the reality is hindi nyo siya magagawa, hindi nyo ma-master lahat yon, kahit ako hindi ko kaya yon. Given the time na meron tayo, I think 60 plus days na lang before the PLE. And so ang gagawin natin, we'll try our best na parang kunin yung 20% of the topics, the concepts that will most likely make up or will most likely come out of the PLE, no? Yung 80-20 rule. So ito yung based from the feedback ng mga students nung March 2023 PLE and yung October 2022, these are the topics na kailangan nyo ma-master. Okay, so we'll go through this in the next hour. So just bear with me. Okay, so we'll start with cardiology. So ang gagawin natin, so hindi ito buong cardiology. Okay, so nag-pick lang ako ng mga specific topics and concepts. Okay, so under cardiology, let's go to CCS. So sa CCS, chronic coronary syndrome, which was previously called ischemic heart disease and previously called CSAP or chronic stable angina pectoris. Now, under nun, meron tayong tinatawag ng mga anginal equivalents. So pag sinabing anginal equivalents, ito yung mga signs and symptoms na na-experience ng mga patients when they, wait lang, e-presenter. Okay, sorry. So ito yung na-experience ng mga patient na ito yung mga symptoms na na-experience ng patient na may ischemia na hindi anginal pain, na hindi chest pain, no? So ang anginal equivalents natin, dyspnea, faintness, fatigue, and nausea. But it happens not only in women and older adults. So idagdag nyo dyan yung mga patients na may DM, okay? So tandaan ninyo yung mnemonic na WED. Tulad ngayong araw na to, today is Wednesday, WED. So yung yung WED is women, elderly, and mga diabetics, type 2 diabetics. Sila yung population of patients na nakaka-experience na anginal equivalent. So meaning, in a patient na like 70-year-old female na may diabetes, so female siya, elderly siya, and diabetic, na nag-present sa ER with fatigue, nausea, and dyspnea, kahit na walang chest pain, you should always rule out ACS. Okay? So that's it for anginal equivalence. So kailangan yung tandaan ninyo. Ang tandaan ninyo ay yung mnemonic natin na WED. Okay? Next, the way na we classify patients na may angina, na may CCS, is itong CCS din. Okay? So don't confuse yung CCS with CCS. CCS is chronic coronary syndrome. Ang pang-classify CCS din, Canadian Cardiovascular Society classification. Now, madalas na kasing lumalabas sa PLE yung mga scoring system, yung mga tables, mga numbers. So which is why most of makikita ninyo sa mga slides ko is emphasizing na kailangan nyo i-memorize yung mga certain tables and certain numbers. And we'll start with this CCS table. So the way na pwede nyo tandaan ito, itong CCS table is letter O, ordinary physical activity does not cause angina, is 1. Okay, so 1, 0, so O. 1 starts with O, and then ordinary physical activity does not cause angina, or O, then ordinary, okay? And then 2 is slight limitation of ordinary activity. So the way na tinandaan ko yan is yung number 2 sinulat ko, and then pag ang mirror image ng 2 is parang S, no? So class 2 CCS is slight limitation of ordinary activity. Marked limitation, so the way I remembered it is itong 3 na to is nilagyan ko ng ganyan, so mukha siyang letter M, marked limitation of ordinary physical activity, and obviously yung talagang wala nang magawang kahit anong activities is class 4 CCS. Okay, so that's how you should remember that. And also you should remember yung mga examples. Okay, let's go to ACS. Now ACS, kung under ng CCS yung CSAP or yung IHD, yung chronic stable angina pectoris, dun yun yung sa CCS. Ano namang disease entities yung under ng ACS? So we have 3 disease entities under ACS. We have unstable angina, kanina kasi stable, unstable angina, non-STEMI, and STEMI. Okay? And yung difference nila is based sa troponin and sa ECG. Unstable angina is, ang ipapakita niya lang sa'yo is mga T-wave changes tsaka mga ST segment depressions. The same sa non-STEMI, ST segment depressions. But yung difference ng unstable angina sa non-STEMI, si unstable angina, negative ang troponin. Si non-STEMI is ST segment depression and positive yung troponin. Si STEMI obviously is ST elevation, yung ECG, hindi ST segment depression, ST elevation, and positive yung troponin. Okay? And yung management nila nagde-differ kasi si STEMI lang yung may ganitong algorithm. So I included this algorithm here to show you kasi may mga students na na-confuse when it comes to interpreting yung mga numbers. So mahalaga yung numbers, guys. So ito, tingnan nyo muna. Negative 90 minutes, negative 120 minutes, negative 30, ang daming numbers. So the first question that should come to your mind, pag may patient na pumasok sa ER or sa question stem sa PLE, is saan ba siya na-admit? Sa non-PCI capable or sa PCI capable? So pag sabing PCI capable hospital, yung mga tertiary hospital, mga Maddox or PGH, okay? Or nakita ba siya sa non-PCI capable hospital, mga primary hospital, mga siguro barangay health center, ganyan. So non-PCI capable hospital yan. So pag nakita sila sa PCI capable hospital, yung FMC to device time should be less than equal 90 minutes. Meaning yung FMC is first medical contact to device time. Device is the angioplasty. Meaning in 90 minutes or less, dapat pagpasok niya sa PGH is in 90 minutes or less, ma-angioplasty siya. So pag pumunta naman siya sa non-PCI capable hospital like barangay health center, or sige, primary hospital na lang, is yung FMC to device time is lumaki ng from 90 naging less than equal 120 minutes. Okay, why is that? Kasi nadagdagan siya ng DIDO time. Ang DIDO time is door in, door out, meaning pagpasok ng patient sa primary hospital up until the time na lumabas siya ng primary hospital, kasi i-refer mo siya or ita-transfer mo siya sa tertiary hospital na PCI capable, yung time from arrival to pag-transfer should only be 30 minutes. Okay? That is why naging negative 1, That is why less than equal 120 minutes ito. Bakit? Kasi ang difference ng 90 at 120 is 30. Kasi napatungan siya ng 30 minutes. May 30 minutes na naging allowance yung patient pag dumating siya sa non-PCI capable hospital. So 30 minutes on top of the 90 is less than equal 120 minutes. Okay, so yun yung reason kung bakit less than equal 120, yung FMC to device time pag dumating siya sa non-PCI capable hospital, kasi nga may nakapatong na less than equal 30 minutes, which is the DIDO time. Pero pag dumating siya sa non-PCI capable hospital, and sa tingin mo is hindi mo siya matatransfer within less than equal 120 minutes, that's the time na ikaw ay mag-administer ng fibrinolytic agents, like for example alteplase. Okay, so gagawin mo lang yung pag-administer ng fibrinolytic agent if the FMC to device time, which is yung pag-transfer dun sa tertiary hospital, will take you more than 120 minutes. For example, kung malayo yung pagtatransfer na tertiary hospital na PCI capable. Okay? So I hope that clears things up. Okay, so that's for STEMI. Okay, just to clarify, sa STEMI nyo lang makikita itong algorithm na ito. Hindi nyo ito makikita sa unstable angina sa non-STEMI kasi hindi ganyan ka-urgent yung need for PCI sa non-STEMI compared sa STEMI. Kasi sa STEMI is transmural infarct yan. Kung naalala nyo sa patho, transmural infarct si STEMI, samantalang si non-STEMI and si unstable angina is subendocardial infarct lang. Okay? So kung baga ganito si non-STEMI, ganito kakapal yung infarct sa STEMI. Transmural infarct. Okay? Let's go to valvular heart disease. Tandaan niyo ito kasi one of the strategies sa determine kung ano klaseng murmur yung present sa patient is number one, timing, kung systolic ba or diastolic. Radiation, for example, nagre-radiate sa axilla, that's mitral regurgitation. Pag nagre-radiate sa carotids, that's aortic stenosis. So radiation. And the third one is yung location, kung saan siya best heard. And these are the locations kung saan best heard yung mga specific na murmurs. So for example, sa aortic area, yung aortic stenosis, which is sa second right ICS. Okay? So I'll just leave that to you para aralin. Pero yung most common na tinatanong sa PLE is the MS and the AR. Okay? So ang MS, well, most commonly it's caused by rheumatic fever. And ito yung hahanapin ninyong buzz phrase sa MS. Yung opening snap, and yung low-pitch rumbling diastolic murmur at the apex. At the apex kasi mitral, diastolic murmur kasi stenosis siya, mitral stenosis, and low-pitched kasi stenosis. As you will notice, yung mga stenosis is mga low-pitched, and yung mga regurgitation ay high-pitched. Okay? If you'll notice that. Okay? Opening snap, makita nyo lang yan sa MS. Tandaan nyo yun. Okay? AR, aortic regurgitation. Now, tinatanong madalas si AR kasi napakaraming mga murmurs na pwedeng makinig sa or mga eponyms na pwede ninyong makita sa AR. No, ang tinanong nung March 2023 was yung Corrigan's pulse or the Waterhammer pulse. Okay? Ito 'yon. Okay, so as I said last time, sa PLE hindi na ulit yung questions, pero naulit kunwari hindi na ulit yung questions exactly, pero nauulit yung mga, like pwedeng matanong yung mga topics and concepts surrounding yung question na yun. So for example, ang tanong is Corrigan's pulse. Pwedeng next time ang itanong na sa'yo is kung ano yung pulsating nail bed, which is Quincke's pulse. Or itanong sa'yo yung to and fro, yung booming pistol shot sound with Straub sign or yung to and fro murmur ng Duruzia sign. So the way I remember that is booming pistol shot Traub sign. Pistol Traub. Okay, pareha sa T. Paano po, Doc, yung to and fro murmur? So yung ang tandaan niyo, Durozies, dalawang Z. Durozies is para siyang nagzizigzag siya ng ganun, para siyang to and fro murmur. Durozies, nagzizigzag to and fro murmur. Okay? So para hindi kayo malito sa exam. Okay? And then, yeah, so ayan yung mga most common na pwedeng itanong sa PLE. Okay, itong mga eponyms na to. Let's go to heart failure. Again, for the PLE, madalas tinatanong din yung mga most common. So the most common cause of HFrEF is CAD, coronary artery disease. The most common cause of HFpEF preserved is hypertension. So na-discuss natin kanina sa CSAP is CCS or sa CCS is CCS, chronic coronary syndrome is Canadian Cardiovascular Society classification. Dito naman sa heart failure is yung NIHA or New York Heart Association Functional Classification. So medyo different siya yung names, pero pag NIHA, ang ginagawa ko, nagsisimula ako dito. So isusulat ko yung stage 1, 2, 3, 4, and then magsisimula ako sa 2 magsulat. Lagay ko muna dito sa 2 is ordinary, and then lalagyan ko ng greater sa taas, and then less than sa baba. So ordinary, mag-start ako magsulat. So kasi the way na i-remember ko siya, sulat ko siya sa papel, no? So stage 2 ordinary, greater than ordinary, less than ordinary, and then at rest. Okay? So tandaan niyo yan. Kasi I think tinanong yan sa October 2022 or March 2022. Nagbigay ng descriptions ng functional classification and then pinaklasify ko anong stage ng NIHA. Again, hindi yun pwedeng there's a small chance na maulit yon, pero pero this time baka itanong na yung examples ng NIHA. So okay? So tandaan niyo yan. Let's go to asthma. So the way na ma-diagnose ang asthma is itong tatlong to, the respiratory symptoms and the spirometric findings. So sa asthma, ang FEV1 FVC, FEV1 is forced expiratory volume 1 and then forced vital capacity. FEV1 over FVC is less than 0.75 to 0.80. Okay? And then, maliban sa obstructive pattern na to, makikita nyo sa spirometry, is there should be evidence of variable expiratory airflow limitation. So ano yung sabihin nun? Itong apat na to. Okay? So bakit ko ito nilagay dito? Kasi gusto kong ma-master ninyo or masigurado ninyo na hindi kayo magkakamali dito. Kasi, tingnan nyo, ang definition daw ng variable expiratory airflow limitation is reduced FEV1 that increases by more than 12%. Pay attention to this conjunction. It is and, not or, and. Kasi ang pwedeng gawin sa PLE, reduced FEV1 that increases by more than 12% or by at least 200 ml. Iyon ang sinagot mo kasi nakita mo yung 12 and 200 which is wrong. Dapat yung sasagot mo is pag nakita mo yung conjunction na and. It should be and. More than 12% and at least 200 ml from baseline na FEV1 post-bronchodilator. Post-bronchodilator. Pag hindi mo nakita yung post-bronchodilator na at the end of the sentence, hanapin mo to. After 4 weeks of steroid trial. Parehas lang sila ng first half of the sentence parehas lang, pero the second half of the sentence is magkaiba. Kasi itong pangalawa na ito is after 4 weeks of steroid trial. Again, and yung conjunction. Okay? So hindi kayo magkamali dapat doon. So the way na dinadiagnose natin ang asthma is itong flow chart na to. This is almost the same as what you can see sa GINA 2023. That is GINA 2022. The treatment for, I will discuss later kung ano yung difference ng, yung big differences ng GINA 2020 previous GINAs to the present GINA ngayong 2023. But let's go first dito sa treatment. The treatment for asthma is ICS formoterol and the controller is also ICS formoterol as you will see later. Okay? ICS ang treatment. Hindi pwedeng SABA. Okay? Hindi pwedeng SABA lang. Okay? So, ito yung GINA 2021. Ito yung GINA 2023. Okay, so what are the differences? Number 1, is hindi nila in-introduce, pero sinabi nila explicitly na yung track 1, yung preferred management ng GINA for adult patients with asthma, track 1. And ang ginawa daw nila is dinagdagan nila ng more evidence supporting yung kanilang stand na track 1 ang preferred nila na treatment regimen for adults with asthma. Okay? Ang isa sa well, aside from the evidence na nandun, is the second one is sinabi nila dito na simpler regimen si track 1. Bakit simpler? Kasi readily available kasi kahit sa Pilipinas, itong ICS formoterol, low dose ICS formoterol, makita niyo yan ang brand name niyan is Symbicort or budesonide formoterol, bud form, na may kinig mo yung mga pool mo magsasabi noon, bud form, budesonide formoterol, that's low dose ICS formoterol. Now the track 2, this is less preferred kasi hindi siya simple. Kasi magte-take ka ng ICS, magpa-puff ka ng ICS, and then separately, on a separate puff is yung SABA. Every time na mag-ICS ka, magsasaba yung patient. every time na mag-ICS yung patient, magpa-puff din siya ng saba. Now, ang nakita nilang problem doon is pwedeng mangyari na puro saba lang yung pinapuff ng patient, hindi na siya nag-ICS. Kasi since we all know that asthma is there's an underlying inflammation sa airways, pag saba lang ng saba, nagbo-bronchodilate lang yung airways, hindi na-address yung inflammation kasi hindi niya ginagamit yung ICS. That's the problem with track 2 kasi separate yung ICS in yung saba. But actually, meron ding ICS saba na na-introduce na combined. Ito yon. Pero ang problem is mahirap siya mahanap. Actually, wala daw available na ICS saba sa Pilipinas. Sabi ni Sir John Ray, yung nag-lecture na about pulmo. Walang available na ganun sa Pinas. Which is why more complicated si track 2. Okay? And another change na ginawa nila sa GINA 2023 is they introduced nga itong ICS saba na to. Kasi as you can see dito sa 2021, ang reliever sa track 2 is saba lang. Dito, as needed saba or as needed ICS saba. Okay, pero ang problema nga doon, hindi siya readily available as of now. And so ang tanong, ano pong susundin namin? Si GINA 2023 or si Harrison's? Actually, medyo magkaparehas sila ng recommendation. As you can see dito sa table sa ilalim, this is from Harrison's na 21st edition. And the reliever therapy, sabi sa Harrison's, is ICS formoterol or SABA. So as you can see, para siyang reliever, kamukha niya si track 1, ICS formoterol. Pero hindi niya lang sinabi si SABA. Ang regular therapy ni Harrison's is low dose ICS din, formoterol. Same kay track 1. Okay? So sa PLE, pag tinanong ano yung preferred reliever therapy, ang isasagot nyo, ang hahanapin nyo muna is si ICS formoterol or si budesonide formoterol or si Symbicort. Siya yung hahanapin ninyo. Okay? Ngayon, in the event na walang reliever therapy, doon sa question of what is the reliever therapy of choice for patients with asthma, kung wala si ICS formoterol, doon papasok, sa kanyo lang hahanapin si SABA as reliever. Kasi nakalagay dito sa Harrison's is or SABA. Pwede si SABA. Pero hanapin niyo muna si low-dose ICS formoterol as reliever and as controller. Kasi ito yung controller, itong bright orange sa taas, no? Low-dose ICS formoterol, step 1, 2, ICS formoterol 3, ICS formoterol 4, nagkaiba lang sa dose kasi yung isa low-dose, yung isa is medium dose. And then sa step 5 is high-dose ICS formoterol. So lahat sila ICS formoterol, okay? So ang message dyan is hanapin nyo si ICS formoterol, okay? The other changes sa GINA is ito. Pero actually, pinost ko lang to, hindi nyo to kailangan memorizing, hindi nyo to kailangan picturean. Kasi I doubt na itatanong to sa PLE kasi pang resident fellows na to, okay? Pero pinakita ko lang sa inyo na merong other changes sa GINA, pero hindi na siya board relevant for you, okay? Okay, so that's for asthma. Pero paano naman kung severe asthma like asthma exacerbation? The initial treatment based from Harrison's is still SABA. Magkaiba kanina. Kanina is asthma lang, hindi exacerbation. This is exacerbation. The initial treatment, not the only treatment. Initial treatment is SABA. Okay. COPD. The spirometric criteria dito, kanina sabi na natin sa asthma is 0.75 to 0.8. Ang spirometric criteria for COPD is less than 0.7. So medyo magkaiba. Okay? So before I move on sa next slide sa treatment ng COPD, let me just emphasize, wala dito yung PE, naalis ko yata yung PE na slides. Pero let me just emphasize na walang digital clubbing, walang finger clubbing sa COPD. Wala. So the only time, so paano pag yung patient na may COPD is merong clubbing? It should prompt the clinician, sabi sa Harrison's, pag ang patient na may COPD ay may clubbing, it should prompt the clinician to find for any sources of malignancy sa patient or any sources or any other cause for the clubbing. Kasi hindi COPD yun. In the case of a patient na may COPD na nagsismoke, na may heavy smoking history, hanapin mo is lung cancer. Okay? Kasi lung cancer can cause clubbing, among other things. No? So, dati, ang treatment for COPD is ABCD. Okay? Yung pag-assess ng symptoms and risk of exacerbations is ABCD siya. Pero ngayong yung latest na GOLD assessment tool is ABE na lang. ABE. Okay? Now, bakit ko pinost ito kahit na-discuss na to ni Sir John Ray? Kasi I want you guys to memorize itong table. Okay? Okay, mahalaga tong table na to. I think tinanong to nung March 2023 or October 2022. So the way na i-memorize ko to, para lang madali sa inyo, is MMRC grade 0 is O. Grade 0, strenuous. Okay, may malaking O dito. Okay, may malaking 0 dyan. Strenuous exercise. Or strenuous dapat yun, pero strenuous para matandaan nyo. Grade 1, I get short of breath when hurrying on the level. So imagine nyo to, imagine nyo, yung number 1 na yan is ihiga ninyo, natumbay si number 1, naging ganyan. So, and then, so para siyang leveled ground, no, yung 1. Or pwede rin si 1 is i-draw ninyo na ganito. Okay, naka slightly uphill si 1. Okay, so that's si grade 1. Si grade 2, paano yung tatandaan? Si grade 2, lagi siyang may kinocomparean. Siya and isa pang pinagko-comparean niya. Dito, I walk slower than people of the same age. May pinagko-comparean siya, yung friend niya na same age on the level. And, or I have to stop for breath when walking on my own pace on the level. So kanina, pinag-compare niya sa friend niya na same age on the level is walk slower siya. And then, yung isa pang grade 2 na example is when walking on my own pace. So kinompare niya yung pace niya na slower dun sa previous self niya na hindi slower. Okay? Kasi kinompare niya sa own pace, sa other. So kinompare niya yung self niya sa other self niya, no? Parang ganun. Lagi may pinagko-comparean. So grade 3, the way I remember it is ito, 100 meters. So 100 is a 3-digit number and meters is yung 3, pag hiniga mo yung 3, di ba? Para siyang ganyan. So M, 100 meters. Bakit kailangan yung tandaan yun? Para hindi kayo ma-confuse na siya ay centimeters or millimeters or kilometers. Hindi, meters lang siya. 100, 3-digit number. Grade 3, 3 pag hiniga nyo, meters. Grade 4, obviously, is wala na talaga siya magawang kahit ano. Breathless na agad siya. Okay? So in terms of treatment, the most important for stable COPD is smoking cessation. Okay? And tandaan niyo, there are only 3 interventions demonstrated to improve survival in COPD, and that's smoking cessation, O2 therapy, and LVRS or lung volume reduction surgery. Okay? Walang meds dyan. Walang meds na nag-i-improve ng survival in COPD. That's why kailangan nyo itong tandaan. Okay? And another sa part of the treatment of COPD is supplemental oxygenation. And pero hindi lahat. Okay? There are may criteria kung kailan ka mag-start ng oxygenation. Ito 'yon. Okay? So tandaan niyo rin 'to. Okay, RF and ARDS. So na-discuss na 'to ni Doc John Ray. But ang gusto ko i-emphasize sa inyo is yung numbers ulit. Tulad nito, mild, moderate, and severe. I think nung March 2022, lumabas 'to. Hindi nila alam kung yung patient daw kasi ang PAO2 FiO2 o ratio or PFR, okay, PFR nung patient, ang PFR niya daw is I think 200. So hindi alam ng student kung ano yung sasagot niya, mild, moderate, or severe. Kasi 200 saktong 200. So tatandaan ninyo, so the way na gagawin ko to, sulat ko muna sa papel, mild, moderate, severe. And then isusulat ko yung 300 sa tabi niya, 300, 200, and then 100. And then susulatan ko siya na less than equal. Tandaan niyo, less than equal, hindi less than. Meaning, yung patient, and then pagkatapos yung isulat yung less than equal 300, less than equal 200, less than equal 100, sa kanya isusulat yung nandito sa other side niya. Okay? Less than equal 200, PF ratio of less than equal 300 and more than 200. So ano yung number na more than 200? 201 and above. Okay? Meaning, 201 to 300, mild. 101 to 200, moderate. Severe, less than equal, 100 pababa. Kasi less than equal eh. So, ang sagot dun sa student na yun, hindi niya alam kung mild, moderate, severe yung classification ng ARDS, na 200 ang PF ratio is moderate. Okay? Kasi nako-confuse siya, mild ba o moderate? Ang sagot is moderate kasi less than equal 200. Okay, so yun yung tandaan niyo, okay? And sa treatment ng ARDS, isa lang ang may grade A recommendation, and that is low tidal volume. Wala nang iba. Okay? And that tidal volume is 4 to 6. May May mga nako-confuse ng 6 to 8 kung saan, hindi ko alam kung saan nila nabasa yon, pero the answer should be 4 to 6. 4 to 6, okay? Psoriasis. Okay, so the reason na sinama ko yung psoriasis is to emphasize the point na pag ang patient is may widespread psoriasis, UV light ang treatment, and topical glucocorticoids naman ang treatment pag localized na psoriasis, okay? Pero never kang mag-oral glucocorticoids. Dahil, kasi ang topical glucocorticoids, pwedeng matagal mo yan gamitin. More than 7 days, more than 14 days, wala masyado magiging problema. Well, magkakaroon ng skin atrophy. Pero, pag nag-oral glucocorticoids ka sa patient na may psoriasis, eventually, i-withdraw mo yan. After 7 days, tatanggalin niya nung nag-start ng oral glucocorticoids. And the moment na tinanggal niya yan on the 7th day, dahil sa tingin niya okay na yung oral steroids, the moment na tanggalin niya yan, i-withdraw niya yung steroids, it can lead to life-threatening pustular psoriasis. Okay? Kasi there are different kinds of psoriasis. The most common is plaque type, guttate type, and pustular type. And the one that comes up when you withdraw the oral glucocorticoids is the pustular type. And yung guttate type naman, yun pwedeng mangyari after an URTI with beta hemolytic streptococci. Okay? And then, okay? So yun, sabi ko, topical ha, hindi oral. Glucocorticoids, localized, UV light, widespread. SJS10. So the reason na sinama ko naman si SJS10 is, sorry, wait lang. Okay, so the reason na sinama ko si SJS10 is para ipakita itong table na to sa inyo guys. Kailangan nyo i-memorize ito. Yung type 1, 2, 3, 4A and yung examples. Okay? Because I think a student asked kung ano ba talaga yung classification ng SJS10. So the answer to that is type 4C. Because I think may naka-mention na immune complex daw yung pathophysiology behind SJS10, which is not true. So you should remember nyo, type 4C si SJS10. Okay, it's part of delayed type hypersensitivity, which is the definition of type 4 hypersensitivity. And so aside from memorizing kung ano yung mechanism for type 1, 2, 3, 4, i-memorize nyo yung mga disease entities na classified under those sa type 1, 2, 3, 4. Okay? Okay, hindi ko sinama yung cancerous skin lesions. Okay, sa hematology, may I understand na pwede kayong ma-confuse kung ano ba talaga si iron deficiency anemia. Siya ba ay normo-normo or hypo-micro? Okay? So the answer to that is depende. Okay, kasi based dito, this is a flow chart from or an algorithm from Harrison's, and it says here na yung iron deficiency daw is normo-normo. Pero actually pwede rin na microcytic hypochromic si iron deficiency pero wala dito, no? Pero nakikita niyo 'yon, tinuturo 'yon, microcytic hypochromic iron deficiency anemia. So it could be both. Depende sa kung nasa stage of evolution na yung iron deficiency niya. Kasi iron deficiency anemia goes through stages from negative iron balance, tatlong stages ng IDA, negative iron balance, iron deficient erythropoiesis, and IDA, like full-blown IDA. And in the first two stages, normal ang RBC morphology. It is only pag pumunta na siya sa full-blown iron deficiency anemia na magiging siya microcytic hypochromic. Okay? Pero in the first two stages, normal ang kanyang RBC morphology. Okay? And aside from IDA, hindi lang IDA yung magpapakita ng microcytic hypochromic na picture sa RBC morphology. Okay, aside from IDA, there are three other diseases na pwedeng mag-present with microcytic hypochromic: inflammation, thalassemia, and sideroblastic anemia. Nagdi-differ lang sila based sa TIBC, percent saturation, and ferritin. As you can see here, sa iron deficiency anemia, mataas ang TIBC, total iron binding capacity, mababa ang percent saturation, and mababa ang iron stores in the form of ferritin, intracellular iron stores in the form of ferritin. The opposite is true for inflammation. mababa ang TIBC ni inflammation, mataas ang well, percent sat is medyo magkatabi lang, pero mataas ang ferritin niya. Why? Kasi if you can remember sa inflammation, sa inflammation dahil yung liver ay nagpo-produce ng IL-6 or interleukin 6, it also induces the production of hepcidin. At ang ginagawa ni hepcidin, pine-prevent niya yung pag-release ng intracellular iron stores in the form of ferritin. Pine-prevent ni hepcidin yung pag-release ng intracellular iron stores from ferritin papunta sa blood. So ang mangyayari, walang iron yung mga RBCs and magiging silang microcytic hypochromic. Okay? And so magiging microcytic hypochromic sila. Pero, ang totoo, maraming iron stores yung patients na may inflammation. Okay? Kasi gawa lang ni hepcidin kaya hindi na-release sa blood. Kaya siya mataas ang ferritin. Okay? And other causes of microcytic hypochromic is thalassemia and sideroblastic anemia. Nephrology. So, bakit mahalaga ang hyperkalemia? Kasi lumabas na siya noong October 2022 and March 2023. Ang kailangan yung tandaan is ano yung treatment for the ECG changes na pinapakita ng patient na may hyperkalemia. The answer is you should give IV calcium gluconate. Okay? Pero hindi lang IV calcium gluconate yung pwede niyo ibigay. Okay? Ibibigay yung yung ibang potassium pwede niyo palabasin, i-excrete niyo sa blood using furosemide for example, or pwede niyo papasukin sa loob ng cells with the use of a glucose insulin drip. Okay? As you can see here. Kasi ang ginagawa ng glucose insulin drip, as you can see, pinapapasok niyo yung potassium from ECF to ICF. Okay? So aside from IV calcium gluconate, pwede kayo magbigay ng GI solution, yun nga, glucose insulin drip, and salbutamol, kasi beta agonist can also facilitate the entry of potassium from the ECF to the ICF. And as I said, pwede nyo, aside from facilitating the entry of potassium papunta sa inside ng cells, pwede nyo siya i-excrete sa body with the use of a kyaxylate or cation exchange resin and loop diuretics in the form of furosemide. Now, mahalaga sa hyperkalemia, is itong ECG changes. Tandaan niyo yan. Kung hindi yan lalabas dito sa IM, pwede siyang lumabas sa surgery. I think lumabas niya sa surgery noong March 2023. Na ganito yung level ng potassium ng patient, ano yung ma-expect mo sa ECG. Okay? Lumabas siya sa surgery kasi di ba sa surgery may nutrition na chapter? I think dun siya lumabas. Okay? All right, so that's for hyperkalemia. Let's go to AKI. So the thing with AKI is yung definition ng AKI yung lumabas. So kailangan yung tandaan nito, guys. Okay? So the way na pwede nyo siya tandaan, actually wala akong mnemonic for this one, pero ang pwede nyo gawin is i-arrange nyo muna, sulat kayo ng 6 hours, 48 hours, and then 7 days. Sulat nyo sa papel. Okay? And then, after that, sulat nyo katabi nung 6 hours, 48 hours, and 7 days yung UCC. Parang coffee, di ba? Yung UCC coffee. Kasi UCC, kasi urine output ang tinutukoy mo dito sa una. CREA dito, and then CREA dito. Urine output of less than 0.5. Okay, wala akong mnemonic for that. Pero tandaan niyo, kasi normally, the normal urine output is 0.5 ml per kilo sa 0.5 to 1 ml per kilo. That's the per hour. That's the normal urine output for adults. So kung less than 0.5, pwede mo siyang tawagin na AKI. Alin lang dyan ang ma-satisfy mo, matatawag mo na siyang AKI. Okay? And then, on the second criterion, na next 48 hours, creatinine naman ang tinutukoy natin, increasing creatinine by at least 0.3 milligrams per deciliter, and then 0.5 times increase in baseline serum creatinine within the next 7 days. Now, makikita nyo sa Harrison's is 50% increase from baseline, which is the same thing as 0.5x. Okay, so kung 1 milligram per DL yung creatinine niya 6 days ago, tapos ngayon is naging 1.5 milligrams per DL, then pwede mo siyang tawagin na AKI. Okay, this is just the same thing as kanina. Okay, ito yung, kasi I think nung March 2023 lumabas daw twice on the same exam. Yung ano daw mangyayari sa GFR pag nagbigay ng NSAIDs, and then the next question is paano pag nagbigay ng ARBs or ACEIs. So I'll just explain it here. Kasi so this is the afferent arteriole, pumupunta yung blood papunta dito, and then some of the blood ay mag-exit papunta sa efferent arteriole, no? And then they will sila yung nagpe-play ng role sa pag-maintain ng GFR. So sa afferent arteriole, merong prostaglandins. Okay? So pag nagbigay ka, and yung prostaglandins na yun, ang effect niya is vasodilatory. Okay? Vasodilation yung effect niya. Now, anong nangyari pag nagbigay ka ng NSAIDs? So afferent ito ha, tandaan nyo, afferent. Pag nagbigay ka ng NSAIDs inhibit COX1 and COX2, which is the reason it inhibits COX2, which is the reason why it inhibits COX1, which is the reason why nakakapagpa-ulcer, no, ang NSAIDs, like for example, ibuprofen. So it inhibits COX1, cyclooxygenase 1, and cyclooxygenase 2, which is for pain. Kaya nga na-invento yung mga celecoxib COX2 selective inhibitors. Anyway, so yung NSAIDs, ini-inhibit na ng cyclooxygenase, which and ang cyclooxygenase are the enzymes responsible for the production of prostaglandins. So, pag nabigay ka ng NSAIDs, mawawala yung mga prostaglandins, magdi-decrease yung levels nila sa afferent arteriole. So, mawawala na yung vasodilation na binibigay niya. So, magko-constrict siya. So, pag nag-constrict itong afferent arteriole, hindi mo ma-maintain yung GFR. Another thing naman, paano naman pag nagbigay ka ng ACE-ARBs? Ang ginagawa kasi ng ACE-ARBs is normally, kino-constrict niya. No, so kung si prostaglandins is pinapadilate niya to increase the pressure here, mag-increase yung GFR. Ang ginagawa niyang normally naman dapat nagko-constrict, okay? Normally dapat nagko-constrict si efferent arteriole para hindi mag-exit yung blood papunta doon sa efferent. Dapat mag-constrict ito para yung blood is maipit papunta sa glomerulus para mag-increase yung GFR. Pero anong ginagawa ni ACI tsaka ni ARBs? Ni-inhibit niya yung angiotensin, which plays a role sa pag-constrict ng efferent arteriole. Pag inhibit niya yung production of angiotensin, so yung efferent arteriole is malaki na, hindi na siya constricted. So what happens is some of the blood exits through the efferent arteriole, decreasing the glomerular pressure, increasing the chrea. Okay? So, kaya masama ang pagsamahin ng NSAIDs and yung ACE-ARBs. Masama pagsamahin. Okay? Pero in-explain ko lang dito yung effects nila. So, that's something na kailangan ninyong tandaan. Okay, CKD. So, pinresent ko lang itong sa CKD na to kasi gusto ko makita ninyo yung kailangan nyo i-memorize yung numbers. Okay? Yung CKD stage 5, stage 4, 3B, 3, 8, 2, and 1. Okay, tandaan nyo lang yun, guys. And itong A1, A2 na albuminuria staging sa CKD. Okay. Tandaan nyo rin to. Lalo na yung normocytic normochromic is observed as early as stage 4, stage 3, and then universal by stage 4. Tandaan nyo yun. Now, and importantly, yung leading cause of morbidity and mortality in patients is in patients with CKD, hindi sila namamatay dahil sa CKD nila, namamatay sila dahil sa cardiovascular disease. And, okay. So, uremic pericarditis is an absolute indication for the urgent initiation of dialysis. And aside from uremic pericarditis and as an indication for the urgent initiation of dialysis, is meron din tayong ibang commonly accepted criteria, which are these ones. So, I'll just leave this to you para basahin. Let's go to here. Okay. Okay. Pag ang tanong sa PLE is what is the best initial therapy? Walang sinabi kung ano ang kung anumang therapy yun. And may MNT at may metformin dun sa choices. Pag ang tanong is best initial therapy, sagot nyo yung MNT or yung medical nutrition therapy. Okay? Kasi papasok lang yung metformin pag hindi na, kumari, patient was initially started on MNT, exercise and weight loss, medical nutrition therapy. And then after i-check ulit yung HbA1c is hindi walang mataas pa rin, that's the time na mag-start ka na metformin. Okay? So, between MNT and metformin, MNT muna. Okay? If they are in the same set of options. Pero kung ang tanong is what is the best initial pharmacologic therapy or medical therapy, metformin yun. Kasi hindi naman pharmacologic si MNT or si exercise or si weight loss. Okay? And, so the question, alin ang susundin? Kasi in screening diabetes, sabi sa Harrison's, sabi sa ADA 2023, is to screen all individuals more than 35 years every 3 years. Sa Harrison's is 45 years every 3 years. So, alin susundin? So, nung napag-usapan namin to kanina, we'll just go with Harrison's. Why? Kasi there is a more than 50% chance na matanong ang kukunan ni Board of Medicine ng kanyang questions is si Harrison's and hindi si ADA 2023. Okay? Textbook-based kasi si PLE most of the time. So, we'll just go with Harrison's. So, ulitin ko. Screening in all individuals should start by 45 years old every 3 years based sa Harrison, and yun yung isasagot natin. Okay, we'll just go with that. Okay. 45. Okay, let's just stick with that. Okay. And then another thing sa diabetes is for the past few PLEs, is mahilig sila sa side effects ng mga anti-diabetic agents. So, tandaan nyo lang ito kung sino yung mga nagpo-promote ng weight gain, sino nagpo-promote ng weight loss, and yung mga side effects nila na unique to each class of meds. For example, si biguanides is lactic acidosis. Sa lahat ng yan ng classes of anti-diabetic agents, wala ka makikitang lactic acidosis kundi kay biguanides with is metformin. And yung CHF fractures, kay thiazolidine-diones lang yan. Bladder cancer kay thiazolidine-diones, specifically pioglitazone. And itong headache nasopharyngitis kay DPP-4 inhibitors lang yan. Di mo yan makita sa ibang classes of drugs ng anti-diabetic agents. Tandaan niyo yung side effects, guys. Okay, ang isa pang pwedeng tanong, ito sikat to. Kahit sa PISBIM namin, sa IM exam, is sikat yung side effect ng SGLT2 inhibitors na they can cause UTI, dehydration, or nilalanggam yung ihi. Kasi yung ihi is merong sugar. Kasi that's the action of SGLT2 inhibitor. They inhibit the reabsorption of sugar, of glucose in the urine. So yung may mataas ang glucose ng urine. Okay? So aside from that, tandaan niyo rin yung may established benefit sa mga patients na may CKD and ASCVD, atherosclerotic cardiovascular disease, is itong two classes of agents na to, liraglutide and SGLT2 inhibitors. SGLT2 inhibitors, specifically empagliflozin. Okay? Okay, let's go to DKA. So sa DKA, ang gusto ko lang tandaan niyo, mahirap tong tandaan. Okay, most of the time malilimutan natin yan. Pero para hindi nyo matandaan yan, tandaan nyo lang itong algorithm na to. This is from ADA. The way na tinatandaan ko yan is yung mnemonic na biik. Biik. Okay? Biik is bicarbonate, IV fluids, insulin, and potassium K. Okay? Pero ang pinakamahalaga dyan, pag yung initial treatment for DKA is yung II. Yung insulin tsaka yung IV fluids. Okay? And hindi lahat ng patients na ay binibigyan ng bicarbonate. Ang binibigyan lang ng bicarbonate is yung ang pH is less than 6.9. Okay? Tandaan niyo yung number na 6.9. And then pag ikaw ay magbibigay ng insulin, tulad na sabi ni Doc Harold, is kailangan niyo laging i-check yung potassium. Okay? Kasi aside from insulin na sinosolve ng insulin yung pag-enter ng glucose from extracellular to intracellular space, is papapasukin din ng insulin si potassium, which leads to hypokalemia. So, kailangan nyo i-check yung potassium, okay? Hypoglycemia, hindi ko i-discuss natin lahat, pero ang gusto lang tandaan ninyo is itong response ng body sa hypoglycemia. Okay? So, tandaan nito, insulin, glucagon, epinephrine, IgE, I, G, tsaka E. IgE, yung immunoglobulin E, kunwari. IgE sulat nyo sa left side, and then on the right side is yung first, second, and third. So kung nalimutan ninyo na IgE yun, tandaan ninyo, first defense, number 1. First defense against hypoglycemia is number 1. So tinan nyo yung insulin, no? Para siyang number 1, no? Insulin. How about, sino yung third defense? Kung nalimutan mo sino yung second and third. Sino yung third defense? The third defense is epinephrine. So E, no? So para ang mirror image ng E is 3. Kasi siya ang third defense. Okay? And then, kung naalala mo na si first defense, si third defense, hindi mo na malilimutan kung sino yung second defense, which is glucagon. Okay? Sila yung first defense against hypoglycemia. Okay? And then yung others actually is not that important. Ang pinaka-important is si insulin, glucagon, and si epinephrine. Let's go to hyperthyroidism. Okay? So the initial test of choice sa hyperthyroidism and even in hypothyroidism is TSH. Okay, so ito yung malaking confusion. As I said sa lecture ko, sa hyperthyroidism, after mong mag-start ng treatment, you should repeat the TFTs in the form of FT4 in 4 to 6 weeks. Hyperthyroidism, 4 to 6 weeks. Tandaan niyo yan kasi iba yung range ng number na yan sa hypothyroidism. And another thing na kailangan nyo tandaan sa hyperthyroidism is yung ito. Okay, so lumabas noong March 2021. I think yung mechanism kung bakit may thyroid-associated ophthalmopathy, and the reason is may activated T cells leading to muscle swelling and increased fat retrobulbarly, which leads to the exophthalmos. And ang tatandaan niyo sa hyperthyroidism is in terms of symptoms is ano yung most common and ano yung least common. As you can see here, medyo opposite, no? Pag hyperthyroidism is maliit yung menses niya, konti, oligomenorrhea. Okay? Lahat ay hyper yung heart, mabilis mapagod kasi hyper nga siya, hyper yung metabolism, pero konti yung menses, oligomenorrhea. And then yung signs is the most common is tachycardia, but AFib pag elderly, but yung least common is gynecomastia. As you can see, parehas na tungkol sa reproductive system kasi oligomenorrhea, so konti ang menses, tapos ay tungkol sa breasts, gynecomastia. Well, in males. Okay, and then dahil nga sikat na ang mga numbers sa PLE, kailangan na natin ninyong memorize sa maraming numbers. How many days should a patient who underwent RAI, how many days should that patient avoid contact with children, pregnant women? The answer is 5 to 7 days post-RAI. Walang contact with children and pregnant women. Thyroid storm, hindi ko rin hypothyroidism, okay. Okay, kanina yung initial test sa hyperthyroid is TSH. The best screening test for hypo is TSH. Okay? Again, tandaan niyo yung most common symptom and least common, impaired hearing and serous cavity effusion. Actually, related to dalawa, no? The reason kung bakit may impaired hearing is may fluid collection in the middle ear. And yun yung fluid collection na yun is a type of serous cavity effusion which leads to the impaired hearing. And the most common sign of hypothyroidism is dry, poor skin, cold peripheral extremities. Okay? Okay, ito mahalaga to kung paano mag-interpret ng TFTs sa hypothyroidism. So para hindi kayo malito, okay? Tandaan niyo yung TSH laging mataas. Maliban na lang dito, okay? Laging mataas, high. Basta pag mataas yung TSH, may apelyido ka na. Okay, pagpalagyan natin ito yung first name, ito yung surname. Okay? Pag mataas yung TSH, may apelyido ka na. Pag mataas ang TSH, hypothyroidism. So the next question is primary ba siya? Primary ba siya or mild? Okay? So ang primary hypothyroidism is kung low ang T4 and then kung normal, mild. Okay? Para hindi kayo malito, okay? And then, okay, ito yung malaking question. Kailan tayo nagmo-monitor? So after mo mag-initiate ng treatment sa hyperthyroidism, 4 to 6 weeks ka magmo-monitor ng FT4. Pag ikaw ay nag-initiate ng treatment sa hypothyroidism, the next time na mag-check ka ng TSH, kasi hypothyroidism, TSH is about 2 months or 8 weeks after instituting treatment. And then the next question is, gaano ka naman katagal mag-check ng TSH pag after subsequent change in LT4 dosage? The correct answer is 2 months pa rin. Kasi sabi dito sa Harrison's, 2 months after instituting and then 2 months right after. Kasi the next time na babalik yung patient after 2 months is meron yan dala lagi na TSH para malaman mo kung nasa normal ka ba, nasa high side or nasa low side ng TSH. So 2 months yung after initiating and then 2 months after subsequent change. So itong nasa handout should be 2 months. Okay? 2 months ito. Okay? All right. Okay. So ang screening test for hypo is TSH, not FT4. And ang pang-monitor ng hypo is TSH. Ang pang-monitor ng hyper is FT4. Okay. And then in terms of treatment, it depends sa inyong reference. It could be 30 minutes before breakfast or 60 minutes before breakfast. Pero sabi sa Harrison's is 30 minutes. So pag lumabas yan sa PLE, ilang minutes before breakfast? 15, 30, 60, 80 minutes. So the answer, I think, mag-stick tayo sa the answer should be at least 30 minutes. So we can go with 30 actually. Okay? 30 minutes before breakfast. And then paano naman to? In terms of dose reduction, okay, itong 50, palitan ninyo ng 12.5 to 25. Okay? So it should be half the dose. So this is from Harrison's 21st. So susundin natin yung textbook. So sabi dito, in the elderly, especially those with known CAD or coronary artery disease, the starting dose should be 12.5 to 25 micrograms per day with similar increments every 2 to 3 months until TSH is normalized. Paano dok yung paano dok kung hindi elderly at walang CAD? The starting dose is 50 to 100. Okay? Under 60 years old, hindi elderly, walang evidence of heart disease, 50 to 100. Mas mababa pag may CAD and pag elderly, 12.5 to 25. Okay? Tandaan niyo yung numbers. Let's go to GI. Okay. 8:04 na. Okay, mabilis lang to, guys. Okay, isa pang question. What is the most common cause of lower GI bleeding? Overall, the most common cause of GI bleeding lower GI bleeding overall is hemorrhoids. Okay? Pero pag ang tanong, what is the most common cause of lower GI bleeding na hospitalized? Okay, the answer would be diverticulosis. Magkaiba yun kasi ang hemorrhoids naman, hindi naman siya na-hospitalize lagi. Okay, actually, rarely naman na-hospitalize ang hemorrhoids kung ipapa-opera na lang. Pero like, hindi siya tulad ng diverticulosis na painless massive hemorrhage na talagang dadalhin mo sa ER on the day of na nag-bleed siya. Okay, kaya the most common cause of lower GI bleed na dinadala sa hospital, na na-hospitalize, is diverticulosis. Ang sabi sa Harrison's is the most common, parang verbatim ang sinabi niya, well, hindi verbatim, pero sabi niya, most probably, the most common cause of lower GI bleeding, most common, is hemorrhoids. But if local anal processes are excluded, which includes hemorrhoids, the most common cause would be diverticulosis. Okay? So I hope that makes sense. Okay? So again, sabi nga dito most common daw. Okay, so I think I should have added more qualifiers dito. Diverticular disease is the most common cause of lower GI bleed na hospitalized. Okay? Okay, yun yung dapat dinagdag ko dito. Sorry guys. Pero sa hemorrhoids, overall hemorrhoids ang most common cause of lower GI bleeding. Okay, this is just I think discuss natin doon sa lecture ko. Okay. Again, most common cause, hemorrhoids. Okay. Overall. Okay, pancreatitis. Okay, may question na, I'll just clarify this. May question na about pancreatitis na, ano nga ba? Kasi ang Ang diagnosis ng pancreatitis is kailangan may masatisfy kang 2 of the 3 criteria. Ito yung tatlong criteria. Abdominal pain that radiates to the back, that is the character of abdominal pain for acute pancreatitis. The second is 3-fold or greater elevation in lipase or amylase. And then confirmatory findings sa cross-sectional imaging, which is CT. Now, pag nasatisfy mo na itong dalawa, yung first 2, acute panc na yon. So, kailan ka nagsi-CT scan? Kailan ka nagko-confirmatory findings? Number 1, if the abdominal pain is not characteristic of acute pancreatitis, or if the serum lipase and or amylase is not 3-fold or greater, like maybe 2-fold lang, or maybe 2-fold or less ang elevation ng serum lipase and or amylase. Number 3 na situation is if the diagnosis is still uncertain, that's the time na ikaw ay mag-CT scan ng abdominal CT scan to find kung baka pancreatitis yon. Okay? And actually, hindi mo rin naman ginagawa yung CT scan pagdating ng patient sa ER. Hindi. Ginagawa mo lang CT scan 3 to 5 days into hospitalization. Pag hindi nagre-respond yung patient sa supportive care in the form of hydration, opioids, okay, and NPO, bakit mo gagawin yon? Pag hindi siya nagre-respond doon, kasi you want to look for local complications such as necrosis. Okay? So ito, na-discuss natin doon sa sa gastro na video. I just i-emphasize ko lang na kailangan yung tandaan yung numbers. Let's go to Ruma. 8:08, maybe in the next 7 minutes matatapos ko to. OA, ito na-discuss na natin to. Tandaan niyo usually spare joints is AWE. Okay, ankle, wrist, and elbow. Okay, another clarification sa osteoarthritis. I think dun sa inyong flashcards is nakasulat daw is the initial pharmacologic measure, parang ganon. The initial drug for osteoarthritis is acetaminophen. That is true nung 20th edition. 21st na kasi tayo. Nung 20th edition, yun ang sinabi. Pero na-update na yung evidence. Ngayong 21st edition ng Harrison's, hindi na tayo gumagamit ng acetaminophen as the initial treatment. Why? Kasi sabi nila, of limited efficacy na daw siya and only conditionally recommended lang. So ano nang binibigay natin? NSAIDs na. Okay? NSAIDs. Okay? As you can see here, yun na yung most popular drugs na ginagamit for OA pain kasi they lead to more improvement in the pain versus high-dose acetaminophen. Okay, so hindi na initial pharmacologic of choice si acetaminophen. Hindi na. That yun. Okay. Okay, let's go to RA. I think ang kailangan kong i-re-emphasize sa inyo sa RA is ito, memorize niyo yung mga structural deformities sa hand ng patients na may RA. And, okay, I think ito yung hindi ko na-discuss last time. Ang hindi ko na-discuss last time is kasi sa okay, the DMARD of choice sa patients na may RA, the DMARD of first choice is methotrexate. Huwag niyong kalimutan na may folic acid kasi nga 'di ba tetrahydrofolate reductase inhibitor si methotrexate, which is why kailangan natin mag-add ng folic acid. And aside from, after mo i-start si methotrexate, dadagdagan mo siya ng steroids. Why? Kasi it takes time, it takes a couple of weeks before magkaroon ng effect si methotrexate. So in order for you to control the disease immediately, which is ma-relieve yung pain and inflammation, magbibigay ka ng steroids. So steroids plus methotrexate is yun yung first mo na treatment regimen. Ngayon, kung hindi yun naging effective, pag hindi effective yung first mo na treatment regimen, may tatlong options. Yung first option mo dito is itong oral triple therapy. Okay, hindi ko na siya spell out, OTT na lang. OTT or oral triple therapy, which consists of mesh. Ang mesh na tinutukoy ko is methotrexate plus sulfasalazine plus hydroxychloroquine. Yan ang tinatawag na oral triple therapy. Metho, sulfa, hydroxy, mesh. Okay? Either that or methotrexate plus minus anti-TNF or methotrexate plus minus non-TNF biologic. Okay? So ilagay natin doon. So either may TNF or yung the third choice na pwede mong gawin is walang TNF, Actually, sorry, hindi walang TNF pero non-TNF. Ano po ba yung mga TNF? Ang mga TNF na drugs, okay, ang mga TNF-alpha na inhibitors na drugs is yung mga MAB. Adalimumab, certolizumab, okay, infliximab. Okay, sila yung mga TNF-alpha inhibitors. Sino naman yung mga non-TNF biologics? Sila yung mga anakinra. Kasi ang anakinra is IL-1 receptor antagonist siya. Hindi siya TNF inhibitor. Okay. Okay, bakit kailangan nating sabihin yung mga stuff na yon? Kasi sa PLE, madalas na natatanong yung mechanism of action in classification ng drugs, which is why kailangan nyo matandaan ang mga TNF inhibitors, yung mga MAB, certolizumab, golimumab, adalimumab, and yan yung mga TNF na biologics. Meron din tayong non-TNF biologics for rheumatoid arthritis, abatacept, yung CD8086, CD28 inhibitor ng interaction nila. Anakinra, IL-1 receptor antagonist. Rituximab, I think that's CD20, basta may CD20. So, IL-6 is tocilizumab. Okay? So, kailangan yung tandaan yung mga mechanism of action, classification nila. Kasi tinatanong siya sa PLE. Kung tinanong dati sa PLE was abatacept, tatanungin yung mechanism of action ng ibang drugs. Like yung tocilizumab, yung anakinra. Okay. Okay, na-discuss na natin to. Ang mahalaga sa gout is itong considerations na to. Tandaan nyo to, okay? Na magko-consider ka lang ng ULT therapy. Ano ibig sabihin ng ULT therapy? Ang example niyan is, allopurinol. Kung walang problema sa kidneys. Pero pag may problema sa kidneys, like mataas ang CREA or may CKD, pwede kang magbigay ng febuxostat. You will consider ULT pag may more than 2 acute attacks yearly, kung severity and duration of flares at quality of life, ganyan. Pero hindi ka na magko-consider. Instead, you should be initiating ULT therapy kung meron na siyang uric acid stones, TOFI, or chronic gouty arthritis. Again, remember yung numbers. Ang gusto natin sa gout is manormalize yung serum urate to subsaturation point of 300 to 360 umol or 5 to 6 milligrams per deciliter. SLE, ang mahalaga dito is, I'll just like to reemphasize itong best screening test is ANA, and then anti-dsDNA yung related sa disease activity. Kasi sabi natin last time, di ba, anti-dsDNA is correlated with disease activity, nephritis, and vasculitis. Parehas siya ay specific, pero meron pa kasing isang specific si Smith. Pero si Smith, specific, pero walang clinical correlations, unlike dsDNA. ANA is the best screening test, okay? And then, isa pang pwedeng, ang dapat ninyong tandaan is anti-Ro, yung associated with congenital heart block and subacute cutaneous lupus and neonatal lupus, pero hindi associated with congenital heart block si anti-La. Hindi. Okay, si anti-Ro lang yun. Okay. The treatment is dependent on non-life-threatening or life-threatening. Ang mga life-threatening is mga lupus nephritis, and that's why sa mga may lupus nephritis is you will give IV glucocorticoids and cyclophosphamide and mycophenolate mofetil. Tandaan niyo yung mechanism of action ng mycophenolate mofetil na diniscuss ko dun sa ating video sa Roma. And I would also like to emphasize, memorize nyo tong classification of lupus nephritis. Wala akong masishare na ano sa inyo dito, mnemonic. But kailangan nyo to tandaan. Kasi kung ang tinanong last time was about kung ano yung sino yung ititreat mo sa lupus nephritis, baka ang itanong na next time is classification of lupus nephritis. You have to remember this, okay? Okay, this is my last slide. Drug-induced lupus. Marami yung sa nasa Harrison's, pero this is pwede yung tandaan. Okay, so I'll just leave this to you para tandaan, no? Pero I think ito yung last slide ko kasi gusto kong i-emphasize sa inyo na whenever naman nahihirapan kayo maghanap ng mnemonic, you can always, well, mostly naman, di ba, may mnemonics na kayo sa top-notch handout. Pero in cases na gusto nyo na walang kayong mahanap na mnemonic na nagsistick, pwede kayong tumingin sa first aid. Yun yung ginagawa ko sometimes, no? And mas madali siya sometimes, no? So just gawin nyo lang kung what works for you, okay? So okay, so I think that's my last slide. Okay. So thank you everyone, and good luck sa inyong pag-study.
Some questions, Carl, nasagot mo na ba? Yung
Hindi ba, Doc? Okay.
Haven't. Yeah, I have a couple of questions here.
Sige, Doc.
According though to Harrison's, I think this was from the first part of the lecture. There is a mild reduced in the new classification in Harrison's. Pwede ba nating sundan yun? I think this is either angina or coronary, somewhere there.
Hanapin. Okay. There is a mild reduced in the new classification in Harrison's. Do we follow that?
Yeah.
Mild reduced na anong disease nga ito, Doc?
Dali. Kaninong disease pa to? Can we move on to the next one first? Meron dito. Hello po, Doc. Question lang. It was mentioned in the lecture that the first management for acute asthma is ICS. Meanwhile, in the refresher, Doc reiterated SABA as initial treatment. Clarification lang po. Which one should they follow? Is it ICS or SABA for as initial treatment?
Okay. It depends dun sa sinabing initial treatment for. Kasi kung acute asthma exacerbation or acute severe asthma, the initial management, sabi sa Harrison's, is SABA. Acute severe asthma exacerbation is SABA initial treatment. Pero like, kung ang tanong is, asthma, hindi naman siya asthma exacerbation, like asthma siya na hindi exacerbation, like pumunta siya sa clinic and relatively stable, gusto mo siyang i-start sa controller or sa reliever, the answer would be ICS LABA. Okay? A low dose ICS LABA in the form of or LABA in the form of formoterol, kaya sinasabi na low dose ICS formoterol. Okay, if you want to know kung ano yung low dose ICS na yun, that would be budesonide. So budesonide formoterol. So the question, so ang answer doon sa what is the initial na na reliever of choice or initial na controller of choice, that would be ICS LABA or ICS formoterol. Pero kung ano yung initial, pero kung tanong is acute severe asthma or asthma exacerbation, ano yung initial treatment? SABA yung sagot doon. Based sa Harrison's.
That's tricky. Okay, I think docs, I'm not sure if this is the right clarification, pero ang clarification, this under heart failure yung mild reduced in the new classification of Harrison's daw.
Okay. I think what mild reduced. Kasi sa Harrison's, I think is merong HFrEF, yung reduced ejection fraction, and we also have HFpEF. The preserved ejection fraction is if ang EF niya is more than 50 and then less than 40 naman yung pag reduced ejection fraction. Yung nasa gitna nila, yung 41 to 49 na ejection fraction, that's MR, HFmREF or heart failure mid-range ejection fraction. I would have to check kung ano yung I would have to check kung ano yung sabi mo mild reduced. And then siguro i-send ko yung clarification kay Doc Broly. So that pwede kong isabihin sa'yo.
Okay, another question here. I think konti lang naman yung questions natin, no? This one here, medyo mahaba to, Doc, ha? Nakalagay po kasi sa handouts and Harrison's na diagnosis of asthma should increase in greater than 12%. At least 200 ml from baseline. However po sa GINA 2023, greater than 200 ml.
Okay.
And, okay. Yan muna. Tapos meron pa siyang questions. Okay.
I think it's saying the same thing. Kasi sabi, should be increased in more than 12%. So, parehas yun sa GINA and sa Harrison's. And sinabi dito is at least 200 ml from baseline. So, at least 200 ml from baseline, kung gagawin mo siya ng sign, it's greater than 200 ml. So, kung, ang at least 200 ml is, pag sinabing at least 200 ml, that's 200 and pataas from baseline. And sabi sa GINA 2023 is greater than 200 ml. So, that's 200 ulit pataas. So, I think, same lang yung sinasabi niya doon.
Okay.
Na at least 200 or more than 200. It's saying the same thing. And then sa next question, also po, can I ask din po, if given na yung FEV1 FBC less than 0.8, can it be diagnostic po of asthma? Okay. Hindi natin madadiagnose yung asthma using the less than 0.75 to less than hindi natin madadiagnose yung asthma with that value ng FEV1, FVC na less than 0.75 to 0.8. Hindi natin madadiagnose yun kasi before you can even say na asthma yun, number 1 dapat may symptoms. Number 2 is dapat meron siyang yung variable expiratory airflow limitation, which is yung more than 12% na increase and more than 200 ml na increase of the FEV1 post bronchodilator. Okay? So to answer your question na pwede mo ba sabihin na asthma yung less than 0.8, hindi mo masasabi yun kasi you have to have more information, which is yun nga yung variable expiratory airflow limitation and yung symptoms. Okay.
No, go ahead. Sige.
And I doubt ibibigay nila yun sa PLE na which of the following is diagnostic of asthma na less than 0.75 or 0.77 or 0.8. I doubt ibibigay nila yon. Pero pag binigay nila yon, pwede kayong pumili doon sa range ng 0.75 to 0.8. Okay? Kasi nga yung 0.7, yung less than 0.70, that is the spirometric criteria for COPD. Pero I doubt ibibigay nila yung ganun ka. Kasi hindi ka makaka-diagnose ng asthma ng 0.75 to 0.8.
I have a Viber question here. What is the difference between exophthalmos and proptosis? They're both bulging of the eyes.
Okay. I think it's saying the same thing then. Proptosis and exophthalmos. I think it's the same. I think it's the same.
What about this one? For the criteria of acute pancreatitis, do we need to have a reference value, range values for lipase and amylase on the 3 times elevation of amylase? Sige, ang pwedeng mangyari niyan sa PLE sasabihin nila na the lipase is 4 times elevated or 3 times elevated, which means pinag-interpret ka na nila ng kung ilang times elevation yung lipase amylase, or ibibigay nila yung normal values and then ibibigay nila yung result ng patient and then ikaw magko-compute kung ilang times elevated yon. Now, yung reference is ULN, upper limit of normal. So kung upper limit of normal ng amylase, for example lang, ang upper limit of normal values ng amylase, for example, is 10 to 20. So, and then ang result ng patient ay 60. Okay? Okay, 10 to 20, and then ang result ng patient is 60. So yung 60, i-divide mo sa 10 or sa 20? Sa 20, kasi yun yung upper limit of normal eh. So 60 divided by upper limit of normal, which is 20, 60 divided by 20 is 3. So that's 3 times elevated yung lipase. So yun, pwede, yun? Ibig sabihin may isa ka ng criteria na satisfy sa acute pancreatitis. So yun, it's either of those situations. Ibibigay nila sa'yo, pinag-interpret ka na, or may normal values and then ikaw magko-compute. Okay, last of the questions that I've received. Clarify lang po, monitoring. I think this is also an endo part. Hyper and hypothyroidism, what parameter do we use to monitor response?
Okay. So hyperthyroidism, FT4 ang pang-monitor ng response. Sa hypothyroidism, TSH ang pang-monitor ng response. Sa hyperthyroidism is FT4, which is you will monitor 4 to 6 weeks after initiating treatment with methimazole or propylthiouracil, kung ano man ang depende sa case. After initiating that, methimazole or PTU sa may hyperthyroidism, 4 to 6 weeks after that, you will monitor the FT4. And then for hypothyroidism, that's 2 months after initiating treatment with LT4 or levothyroxine, 2 months or 8 weeks.
Okay. Yeah, I think I heard that during your endo part, no?
Mm-hmm.
Okay, we have no more questions here. Last call for questions for Dr. Carl. If not, let's give the floor to...
Let's have thank you very much, Dr. Carl. Thank you very much, Rocky. Let's have a 5-minute break muna para makapag-wiwi yung mga taong kailangan mag-wiwi. By 8:30, which is sakto, I'll discuss the clarifications collections for about 15 minutes, and then you'll have your Quizmasters for
Okay.
internal medicine immediately. So we'll try to end around 9:15 p.m.
Okay.
A 5-minute break.
Yeah. Starting break at 5 minutes. Thank you, Dr. Carl.
Thank you, Doc.
Suot mga kapatid, tayo ay magsama-sama. Iwagay-way na ang bandera, rock and roll hanggang umaga. Text mo na sina Sean at Jope. Lagyan ng gel ang buhok na bagong gupit.
Trying to get your handouts, everyone. Your IMA handouts. We start in 1 minute.
My apologies for that unfortunate choice of music. We have 1 minute 30. Please call your friends back. 1 minute 30 according to my timer. Sorry about that.
Call your girl.
Okay, let's start, everyone.
Hold on, please.
Okay. Rocky, pa-mute na lang ng ano mo, nung sounds mo.
Okay, nakamute na siya. Floor's yours.
Okay, so some collections clarifications. First, we have a change in the schedule. We've switched your pedia and OBGYN. Pedia will be from August 24 to 26, OB from August 27 to 29. What's the reason for this, Doc? Meron tayong on-site lectures for PEDIA. This will be conducted by Dr. Ian De Vera. Unfortunately, hindi siya pwede ng 27 to 29, 24 to 26 lang talaga. So we have to switch yung dalawang subjects na to para kahit paano, yung mga mag-a-attend ng PEDIA on-site, pag tinignan nila yung mga videos doon sa portal, PEDIA videos din yung nandoon. So it's an accommodation basically for those going to our on-site classes for PEDIA. IM verifications. Let's go through this one by one. Go to page 10, right lower quadrant. So napagbaliktad yung definition ng Trov sign and Durgis sign. However they pronounce that, kung ano man yung pronunciation yan. So Trov sign, Durgis sign, okay, kindly exchange their definition. Okay? Next. Okay? So page 12. Next, page 32, right upper quadrant. Okay. The instruction on the management of liver toxicities in TB treatment. The instruction is to follow the video, okay, instead of the handout. So do not stop TB med unless transaminases are 3 to 5 times elevated. Follow the video. Iba yung nakasulat sa handout. Okay. Nagkaroon ng last minute change. I think this is si Dr. Magallanes. So ang abiso niya sa amin is to follow the video rather the handout for this part. So page 32, right upper quadrant, toxicities related to treatment ng tuberculosis. Okay, next. So minor correction lang, typo. Okay, so ml per kilogram dapat yung units. So go to page 36. Right lower quadrant. Okay. Low tidal volume 4 to 6 ml per kilogram with 9% absolute reduction in ARDS mortality. So I think may mali lang yung spelling. Okay, dyan sa ml per kilogram na yan. Okay, next. There should be an additional row of SARS-CoV-2 treatment in the video lecture. Okay. So for page 52, so kindly take a look. Okay. Kung ano yung hula. Okay, next. So minor correction lang din in terms of the numbers. I think 16, 17 na nakasulat dyan sa handout nyo. So go to page 65, right lower quadrant. Okay, for acute promyelocytic leukemia, APML. Okay, characterized by T1517. Okay, I think nakasulat sa handout nyo ay 1617 instead of 1517. So typo, kindly change. Okay, next. Page 75, mga most common in terms of bleeding. So, inano na yun, in-address na rin kanina naman ni Dr. Carl. Pinag-usapan din ng mga IM teachers the past several days. Again, the most common cause of admitted lower GI bleed is diverticular disease. But the most common cause of UGIB overall, okay, are hemorrhoids. Okay. Lower GI bleed overall is hemorrhoids. Okay, next. Hypersensitivity type, SJS. Okay, Stevens-Johnson syndrome is type 4C. So follow the handout for this one. So connection need to be done sa level ng video. Okay. So page 56, left lower quadrant, SJS type 4. Next. Okay, page 103, TSH monitoring. Okay, so kindly add monitor TSH every 3 to 4 months while on treatment. Okay, so according to Dr. Avilo, based on Harrison's, after starting treatment with T4, measure TSH after about 2 months. After adjusting dosage, measure TSH after about 2 months. Next. Nephrology video regarding NSAIDs and cyclosporine. Okay. According to Dr. Magallanes, sorry for the confusion. In the video, dapat, even if NSAIDs and cyclosporine are working at the glomerular level, they are still considered pre-renal because they auto-regulate blood flow rate or GFR before it enters the glomerular capillaries. Okay, next. Clarifications. Okay, so tama sa handout, may mga kailangan lang i-clarify. Okay, LDL goals in diabetic patients, less than 70 because of the presence of a risk factor. In the table, it's less than 100 milligram for type 2 DM without other risk factors, but less than 70 milligram per deciliter if with one or more risk factor. Okay, so less than 70. Page 18. Next. The use of proton pump inhibitors in patients with levothyroxine, according to Dr. Chu, with PPI use, the intragastric pH increases, causing malabsorption of LT4. In such cases, for instance, hospitalized patients or those in the ICU, we can either give a liquid LT4 formulation or move the time of LT4 administration away from PPI administration. Next, treatment, Quizmaster's angina. So iba nakasulat doon sa pharma handout nyo, iba yung nakasulat sa IM handout nyo. So ang recommended treatment for this is non-dihydropyridines sa pharma handout. And then for cardio, dihydropyridine. So we've consulted the IM teachers, okay, for this one, follow IM basically, okay. So according to Harrison's, variants Quizmaster's angina responds particularly well to calcium channel blockers, especially members of the dihydropyridine class, supplemented when necessary by nitrates. So ano magiging tama? It's dihydropyridines. Okay? Posibleng iba nakasulat sa pharma textbook, but based on the opinions of our clinicians, dihydropyridines ang dapat. So we follow this one. Buong top-notch dihydropyridines ang susundin. Next. Hyperuricemia and anti-TB meds, when to start anti-gout meds. According to Dr. Magallanes, during TB treatment, give meds when symptomatic or when there's gouty flare. Ibang usapan if you have a gouty patient na may baseline indication for gout treatment prior to starting TB meds. Uric acid greater than 9 attacks or at least 3 a year. Presence of tophi, yung indications for maintenance ng gout treatment. Deficiency anemia. So, Doc, nalito yung mga ibang estudyante nalito whether it's really microcytic hypochromic or normochromic normocytic. Kasi pag tinignan daw yung flowcharts na binigay, Doc, yung iron deficiency anemia, it seems nandoon sa normocytic, normochromic, microcytic, hypochromic, parehas. So, according to Dr. John Borbe, who's also going to be your teacher for Michael, basically stages kasi yan. So, initially, if you look at his explanation here, initially, pwede siyang mag-umpisa na normochromic, normocytic, and eventually, after some time, it will develop to become microcytic hypochromic. Classic description pa rin ng iron deficiency anemia is, of course, microcytic hypochromic. So if you're left with just one choice, you will choose microcytic hypochromic. Okay, but take note, in the early stages of iron deficiency anemia, it may present with normocytic, normochromic anemia. Okay, next. So again, lifestyle modification and metformin treatment in type 2 DM. So may mga nagtanong din dito. Okay, page 94, left upper quadrant of your handout. Again, best initial therapy is lifestyle modification. But the best initial pharmacologic therapy is metformin. Okay, and then according to Dr. Chu also, lifestyle modification should be part of the management for all patients with type 2 diabetes. So please take note of the fine print. Best initial therapy is lifestyle modification, diet and exercise basically. And then best initial pharmacologic therapy is metformin. Okay. Next, the type of malignant melanoma with the worst prognosis. So in the surgery handout, it's nodular type. In the IM handout, it's the desmoplastic type. Okay, according to the students. Dr. Mads Abraham clarified this. Ang sinabi daw niya doon sa lecture videos is that yung desmoplastic type is just one of those having poor prognosis. Hindi niya sinabing siya yung absolute worst. Okay? So, verbatim from Dr. Mads, desmoplastic melanoma is said to be often deeply invasive at the time of diagnosis with a tendency to perineural growth. Nodular melanoma is a rapid evolution in a vertical growth pattern, hence with a poor prognosis. In derma textbooks, there was no mention that nodular melanoma is the worst prognosis. But if in surgery it was mentioned to be the worst, let us follow that. Okay? So follow surgery regarding this one and take note yung desmoplastic melanoma is just as of a poor prognosis, one of the worst. Pero hindi stated ni Mads na siya yung absolute worst compared to all types. Okay. Next. That's it for the corrections and clarifications for internal med. I will see you tomorrow. Okay, for the introduction to pediatrics. Okay, Dr. Rocky, Box.
Hi. Sorry, Doc, meron lang question dito. I don't know kung mahabol if Dr. Carr can address this.
No, bigay na sa akin sa FB Messenger. Also, announcement to everyone, when you send messages to me asking for clarifications or questions sa FB Messenger ko, please provide relevant screen caps na. Hingin ko din sa inyo yan. Okay, wag niyo lang banggitin na, Doc, according sa handout niyo, ito yung nakasulat. Give me the actual screen caps because I need to forward them to the teachers para makita nila yung context. Baka kailangan namin i-check kung tama kasi yung intindi nyo, tama yung nakasulat, at ano yung specific context sa handout or sa video. So all questions for IM from this point forward, just message me on FB Messenger. Okay? Sige, Rox, ka na bahala.
All right. Thank you very much. We will now proceed to the Quizmasters. Our next, hold on. Our next speaker, okay, is, ito, lagi akong kinikilig pag dumarating siya, okay? This is Dr. Tiffany Grace Uy. She scored the 5th place, or she bagged the 5th place in the November 2020 Philippine licensure exam, physician licensure exam. So she was top 5. She is also from the University of the Philippines College of Medicine. Right now, she is IM resident in St. Luke's. Okay, tapos, favorite ko siya kasi we come from the same high school. Not that it matters, but Doc Tiff is also, Doc Tiff also comes from where I'm from. Parang feeling ko kasing smart niya ako dahil pareho kami ng school. Does it work that way? I don't think so. Anyway, let's start with our Quizmaster. So, I think how this works is we will show you the questions. I will give you 30 seconds, depending on how long or how short the questions are. I'll give you 30 or 45 seconds. And then after that, we will proceed to Doc Tiff discussing the answers. I'll give you all of the questions first, tapos sagutan ninyo. No? Get a piece of paper and answer them, and then Doc Tiff will discuss them after. Okay? Let's see. Let's share our PowerPoint. Here we go. Doc Tiff, are you here with us na?
Yes po, Doc.
Hi. Okay, so we'll start with the questions. Will you read them or you'll read them na lang, but we'll give him 30 seconds or 45 seconds, okay?
Ay, sure po, Doc.
Okay. Let's begin. Go. Here.
Okay, so question number 1, a 23-year-old male came in for chest discomfort, weakness, and fatigue. He had had previous incidents of fainting and palpitations, and there was a family history of paternal sudden death at 36 years. So lab tests, including the biochemistry panel and the cardiac biomarkers, were normal. The ECG showed a coved ST segment elevation of 4 millimeters, followed by a negative T wave in leads V1 and V2. The 2D echo was unremarkable. So which of the following statements is true about his condition? Is it A, he has a genetic mutation in genes encoding sarcomere protein? B, definitive diagnosis can be established by coronary angiography? C, the therapeutic management includes the sodium channel blocker, procainamide? Or D, screening of all his first-degree relatives is warranted?
Okay, I will give everybody 45 seconds for this. And then after this question, para in the interest of time, hindi na babasahin ni Tiff. I'm just going to show it and give you the number of I'll and do the countdown, no? Sige, Tiff, let's just get ready for the discussion in a while, ha? Okay. 45 seconds, guys. Okay, next question. 30 seconds for this one. Remember to try and answer. Subok lang. Para hindi kayo ma-conscious, wala tayong poll. Kayo na dito, ha?
Rox,
Yeah?
you have to give the students time to answer all 10. Dire-diretso ka agad.
Yeah. Okay, next question. Number 4. Number 5. Number 6. Number 7. Last 2 questions. Number 8. Number 9. Number 9. There you go. Kanina pa ako nag-number 9. Hihi. Oh, shush. Last question, guys. Okay, I shall give the floor now to the cutest and sweetest top-notcher Shobe that we have here in Top Notch. Doc Tiff, the floor is yours. You're naka-mute, honey.
Oh, thank you. Thank you very much, Doc Rocky. Looks like I received the memo today. We're all in black. Okay, so Let's go back to the first question. We have a 23-year-old male. Pertinent here is that this 23-year-old guy came in for chest discomfort. He has history of fainting and palpitations. And very pertinent is, in his family, he has a father who also suddenly died at 36 years old. However, despite he comes in for chest pain, normal cardiac biomarkers, normal biochemistry panel, and on ECG, he has a coved ST segment elevation 4 millimeters on the leads V1 to V2, and the 2D echo is normal. So which of the following is true about his condition? So this is actually a question that came out in my board exam. And we have to know about Brugada syndrome. So Brugada syndrome is one of the inherited arrhythmia syndromes that the characteristic here is you're predisposed to just lose consciousness, to have syncope, and to have sudden cardiac arrest and sudden cardiac death. So what you have to memorize here is the ECG finding, because they have a very abnormal ECG where there is coved ST segment elevation more than 2 millimeters, more than or equal to 2 millimeters, and there is negative T wave in the right precordial leads. So the Brugada syndrome may present with actually not just one, but 3 different ECG patterns. The type 1 is the most typical and diagnostic. So yun yung coved ST segment elevation, followed by a T wave inversion in leads V1 to V3. So yung cove actually resembles the shark fin. Type 2 and type 3 are more on saddleback. So in type 2, you have here a saddleback shape, ST segment elevation, and the terminal point of the ST is elevated more than 1 millimeter here. That's more than 1 millimeter. And in type 3, it's less than 1 millimeter in elevation. Di masyado. So yung memorize here is saddleback. So the ECG actually of Brugada syndrome patients is kind of dynamic. So pwede silang normal in some instances. And then if you find type 2 and type 3 in your patient, you can they have to undergo provocation testing. You give them a type 1 antiarrhythmic, a sodium channel blocker, and it will trigger conversion to the classic pattern. Then you can diagnose it. So the classic presentation as mentioned is syncope, they lose consciousness, or sudden cardiac death, or yung first presentation niya is suddenly namatay at sleep. So these are all high-risk symptoms, no? Here. Also, as well as sustained VTAC. Some intermediate risk factors include having syncope or family history of sudden cardiac arrest or spontaneous na type 1 ECG pattern and atrial fibrillation. So we just have to differentiate between the Brugada syndrome versus the pattern. So the syndrome is when you have the ECG na nga, the classic ECG, and meron ka pang clinical findings. So you have the history of sudden cardiac death or sustained ventricular tachyarrhythmia. Well, pattern is just, you're asymptomatic. You don't have any other features. They just saw the ECG features in your ECG. So the genetics involved here, it's autosomal dominant and it involves a mutation in the cardiac sodium channel. So because parang there's a reduction in the sodium channel current, it causes delay in the action potential. So imbes na yung normal dito na black, nagkakaroon ng delay as you see in the red. And the treatment, for supportive measures, it involves avoiding any antiarrhythmogenic drugs, avoiding alcohol intake, taking antipyretics for fever. Why? Because all of these can actually trigger symptoms in a patient with the Brugada. And for the high-risk patients, the one as shown in the table earlier, the management really is you implant ICD. So inside is an implantable cardioverter defibrillator, such that when they go into cardiac arrest, it will shock their heart automatically. So really pertinent here is that if you have a patient you're suspecting Brugada, you have to screen all the first-degree relatives. So the answer here for question number 1 is letter D. Screening of all his first-degree relatives is warranted. So why? Kasi the genetic mutation here is the sodium channel. The definitive diagnosis is more clinical and ECG findings, so not this, Cadian. And actually, procainamide will induce it pa, so hindi siya management. Okay, let's move on to question number 2. So here, a 51-year-old female, known case of breast cancer, underwent chemo and radiation therapy, presented to the emergency room with 2-week history of progressive shortness of breath. So the vitals are the following. BP of 80/50, so medyo hypotensive, heart rate of 120, RR 22, temperature 36.8, 99% at room air. Patient has distended neck veins. On cardiac exam, distant muffled heart sounds, emergent pericardiocentesis was done. All of the following findings are expected in the patient except which? Absent X descent on the jugular venous waveform, presence of pulsus paradoxus, electrical alterans on ECG, or late diastolic collapse of the RV free wall on 2D echo. So take note, pag may nakita kayong except, bilugan na. Okay. So, cardiac, when you heard this one, the hypotension, distended neck veins, and muffled heart sounds. So these 3 are components of the Beck's triad. The first thing that should come into your head is cardiac tamponade. So cardiac tamponade involves nag-accumulate in the pericardial space fluid. And if there's fluid in that bag, it causes obstruction of inflow of blood into the ventricles. Wala nang blood na kasha inside the bag. So regarding the causes, actually, one of the most common is idiopathic, but the next is malignancy, like in our patient who had breast cancer. What is involved in cardiac tamponade is increased pericardial pressures. As mentioned, because puno yung bag, no? Mataas yung pressures. This impairs the right-sided filling. So there will be increased pressures over here, and there will be prominent and distended neck veins. And then the decreased diastolic filling will cause eventually, wala din kang malalabas kasi walang pumapasok sa heart. So decreased cardiac output and hypotension. And then once you auscultate, because you hear the heart sounds behind a bag of fluid, it sounds muffled and distant. So yan yun, muffled heart sounds. So what are the features that you see in a patient with cardiac tamponade? So one is a very characteristic finding on the jugular venous wave pattern, which is a prominent X descent and an absent Y descent. Quick review lang. So in the normal pattern, A stands for, the hump in the A is for atrial contraction. So when the blood in the atria, when the atria contract, there's a little increased pressure na aakyat. And then the X here, the X descent is once the atria will relax, and then the atrial floor will depress, allowing blood to enter. So the V naman here is for maximum atrial filling, and then the Y here is for slow Y descent or atrial emptying. So in this patient, bakit nagkakaroon tayo ng prominent X descent? Sobrang prominent yung X descent is because when you have cardiac tamponade, there is depression of the atrial floor during the ventricular contraction. And then yung sa Y naman, nagkakaroon ng absence in the Y descent. Actually, this is a more important one, is because it is impeded in cardiac tamponade. Wala ka ng atrial emptying. So wala ka ng, hindi babagsak yung pressure kasi punong-puno na lang siya ng blood. Hindi na siya babagsak further. What else? So for the atrial pulses naman, quite pertinent is also the phenomenon of pulsus paradoxus. So pulsus paradoxus is when humihina yung pulse, and also the blood pressure itself will drop more than 10 millimeters mercury during inspiration. So if you notice here, pag expiration, very strong pulses, pero pag inspiration, very weak na lang yung atrial pulses. And if you check the blood pressure, the systolic BP would drop significantly during inspiration. Now, this is an ECG finding for cardiac tamponade. And if you notice here, the QRS pattern has alternating high and low amplitude. High and low amplitude. So yun yung electrical alterans. Because sometimes when you have the ECG, pag malapit siya sa heart, mataas yung amplitude. Tapos pag lumalayo, bumababa yung amplitude. So pertinent to the echo findings includes diastolic RV collapse. So this part is your RV. And this part is your LV. So what happens is that when the pressure in the pericardium exceeds already the intercardiac pressure, ang nangyari, so sobrang daming pressure from the pericardial space will push the walls of the right ventricle. So the right ventricular free wall will collapse. So just an index card for you to remember. In cardiac tamponade, just remember the Beck's triad. Remember that the venous pulse, very prominent here, prominent X descent, absent Y descent. For the pulsus and then there's pulsus paradoxus, electrical alterance on the ECG, and diastolic RV collapse. So for this question, the answer is letter A. So mali yan, kasi very prominent yung X descent, but the rest are present. Okay. We'll just review a little the pertinent pulses. So like we mentioned, again, the pulsus paradoxus is when you're checking the pulse and the amplitude of the pulse suddenly decreases. The blood pressure itself also drops more than 10 millimeters during inspiration. What conditions can you really find this in? As we mentioned, cardiac tamponade, pwede rin constrictive pericarditis or pulmoembo, yung mga obstructive. Reverse pulsus paradoxus naman is when during inspiration, nag-i-increase yung systolic pressure. What condition is this? HOCM, hypertrophic obstructive cardiomyopathy. Pulsus parvus et tardus is when you have a very slow rising pulse and delayed yung peak. So mabagal, mababa. You can find this in severe aortic stenosis. Kasi sobrang stenosed, wala masyadong cardiac output that way. And as mentioned earlier, remember the Water-Hammer's pulse and the Corrigan's pulse, which is a large volume pulse, rapid upstroke, rapid descent, no? Yan. Water-Hammer pulse, where do you find it again? Aortic regurgitation. What about the pulses bispherians? Ito, in one pulse, meron kang two peaks, so it's a bifid kind of pulse. You can find this in moderate to severe aortic regurgitation as well. Pwede din in other conditions like HOCM or digitalis toxicity. Dicrotic pulse naman is you have two pulses, but this time, kung yung bispherians, both of them are systolic. This one, yung isa systolic, yung isa diastolic. You can find this in dilated cardiomyopathies, pwede din in some cardiac tamponades, not very commonly asked. Pulsus alterans is a beat-to-beat oscillation in cardiac muscle contraction. You can find this in severe left ventricular failure or toxic myocarditis. And last is the hypokinetic pulse. It's a very small, weak pulse, mga hypovolemic or shock states. Okay, so what about the venous side? So a while ago, we mentioned a little about the jugular venous pressure. So the jugular venous pressure waveform, as mentioned, the A waves involve the right atrial contraction. So when the atria contracts, blood will rush up the internal jugular vein. In the X descent, mag-relax yung right atrium. So it will suck in the blood, tas babagsak yung waveform. Kasi mag-relax yung atrium. And then in C is closes, tricuspid valve closes. During this time, the right ventricle will contract. And then for the V, this is the right atrium will fill again against the closed tricuspid valve. So because mag-fill siya, may some pushback of pressure, konti lang. And then the Y is when the tricuspid valve opens, so the blood in the right atrium fills the right ventricle. So babagsak ulit yung waveform kasi it fills the right ventricle. Okay, so just some important stuff to memorize. When you have absent yung A waves, it's atrial fibrillation kasi wala kang good atrial contractile activity in AFib. When you have very large naman masyado yung A waves, it can be seen naman in pulmonary hypertension or pulmonary stenosis, meaning masyadong mataas yung mga atrial pressures. Canon A waves is large amplitude A waves. This can happen in heart block. Kasi minsan, because in heart block, magkaka-simultaneous contraction yung atria and yung ventricle, nagkaka-summative effect and nag-exaggerate yung A waves. So, if you have complete heart block, minsan magka-canon A wave, minsan normal. Minsan canon A wave, minsan normal. Okay, what about sa V wave naman? If you have a very large V wave, that is, for tricuspid regurgitation, in which meron kasi in tricuspid regurgitation, so imagine the tricuspid valve, may backflow ka from the right ventricle to the right atrium. So the backflow is what produces the sucking in dapat of blood in the X descent. Pero kung meron kang backflow, wala kang X descent. So since wala kang X descent, magfa-fuse yung C and V waves. Yan. And then you'll have what looks like large V waves. And then one more thing, the Kussmaul sign. So this one is during inspiration, there can be a paradoxical rise in the right atrial pressure during inspiration. Ordinarily kasi dapat this jugular venous pressure waveform should fall during inspiration because when you inspire, there would be negative and reduced pressures in the thorax. But if you have conditions like constrictive pericarditis, again, may obstruction, umaakyat yung pressures during inspiration. Here, that you observe. So that is Kussmaul sign, which is as opposed to Kussmaul breathing. So for Kussmaul breathing, ito yung rapid gasping, very deep type of labored breathing in severe metabolic acidosis, such as in DKA. So hingal na hingal yung patient. That's Kussmaul breathing. So let's move on to the next question. For number 3, a newly diagnosed PTB patient had taken his HRZE for 1 month. So yan, naka-intensive phase for 1 month. Afterwards, he forgot to follow up at TB dots. He misses medication for the next 6 weeks. So 6 weeks siyang hindi nakatake. As per TB guidelines, what is the correct next step? Do you immediately continue the HRZE and then just prolong the doses to compensate? Do you order for sputum microscopy? Repeat kaagad the sputum gene expert or stop na the treatment and label as treatment failed? Okay, so just a quick run through regarding the TB. So anyone with, regarding the systematic screening program, no? Anyone who has signs and symptoms, meaning 2-week-long cough, fever, night sweats, or weight loss. So either may symptoms ka, or anyone na kahit wala kang symptoms pero may chest x-ray finding ka suggestive of tuberculosis, you already label them as presumptive TB. So you will request for a sputum gene expert to diagnose tuberculosis. So yan, sputum gene expert. So anyone who has tuberculosis, no, na-diagnose mo na may tuberculosis, basta the gene expert says rifampicin sensitive or rifampicin indeterminate, you already put them under regimen 1. Yung counterpart nito is someone na na-diagnose mo na may tuberculosis, pero as mentioned, unfortunately, it already affected this difficult to reach sites like the CNS, the bone, and the joint. You will step it up a little, so you give them regimen 2. Kasi mas mahirap sila i-treat. Also, anyone who is diagnosed na PTB or extra PTB na clinically diagnosed kasi is you weren't able to receive any microbiologic documentation of tuberculosis. So, if you're clinically diagnosed, sige, basta it's your first time, you can also classify them as regimen 1. Okay? Yung counterpart niya is anyone na clinically diagnosed, pero, again, it's the hard to reach area, CNS, bones, and joints, it's regimen 2. For regimen 1, you give them the classic. So 2 months intensive phase, HRZE, then 4 months HR maintenance phase. For regimen 2, it's the same, except your maintenance phase, imbis na 4 months, it's 10 months. So ito-treat mo siya for 1 whole year. Now, anyone not in this category might have to be referred up kasi baka they need to be worked up for possible multi-drug resistant tuberculosis. So, remember, how do you dose them once they're diagnosed? So, alam mo na ang regimen ibibigay. You do it by weight-based. So, 25 kilograms up, you give 2 tabs. So, 2 from 25. 38 kilograms up, 3 tablets. Ito, 50, and then 55 kilograms up. Sorry, nawala na yung mnemonic dito. Pero 55 up, you have 4 tablets. And then anyone 70 kilograms up, you give 5 tablets. So how do you schedule the follow-up? After 2 months, so you give them the intensive phase. After 2 months, request for sputum microscopy. If you're negative, safe. That means you're doing it, we're on the right path, just proceed with the treatment. However, if after the intensive phase, positive ka pa rin, you'll have to request for the TB gene expert. The only reason why we're doing this is because if we were able to detect resistance, then you have to refer up na for drug-resistant TB treatment. Pero otherwise, wala ka naman na-detect na resistance, you can still continue the treatment. But after 5 to 6 months, repeat the sputum microscopy. Dapat talaga negative ka na by this time. If you're positive, you have to stop. It's treatment failure. Now, what about patients who were able to interrupt treatment, such as in our case? So for patients who are interrupted treatment for less than 1 month, you're safe kasi less than 1 month, maikli pa lang yung duration. You can continue the treatment, just prolong it to compensate for missed doses. But if you're within 1 month, less than 2 months, you have to perform sputum microscopy first. So do the sputum microscopy first. If negative siya, then you're still safe. Continue lang and prolong treatment. But if the sputum is positive for AFB, we'll have to look. The next question is, how far na ba into the treatment are we? Because remember, if we're already 5 months or more, it's already treatment failed. Pero if hindi pa tayo umabot sa 5 months or more, then you can still continue treatment. And lastly, if the interruption is more than 2 months, wala na, that's already too much. The too much na yan, you already categorize them as lost to follow up. Okay? So balik tayo sa question natin. Yung patient mo, 1.5 months siya nakapag-miss ng treatment. What is the next thing to do? You order for the sputum microscopy. So again, pag negative, safe. Pero pag positive, TB gene expert. Okay? Next question. A 67-year-old female hypertensive diabetic smoker complained of several days of intermittent chest heaviness associated with dyspnea. So the ECG demonstrated anterior Q waves and ST segment elevation. So yan, may STEMI yung patient. Tapos, on 2D echo, the ejection fraction is only 15%. So the patient was persistently hypotensive and started on norepinephrine and dobutamine. So naka 2 pressors na siya. Which of the following features is consistent with her type of shock? Is it elevated jugular venous pressure, increased cardiac output, decreased systemic vascular resistance, or flushed warm skin? Okay, so let's try to review lang the types of shock. First of all, cardiogenic shock. As in our case, no? Cardiogenic shock occurs because of pump failure. So when there's an injury to your heart, pwedeng from ischemia, arrhythmias, or mechanical valve insufficiencies, it will result in decreased cardiac output. So if ang ischemic area is the right ventricle, hindi siya makakapag-pump ng blood out, you'll have a heart full of fluid, it's drowning in fluid, and then you will have increased central venous pressure up the jugulars. Now, if it affects naman the left ventricle, it will cause elevated left atrial pressures. So yan yung increased pulmonary capillary wedge pressures. Because bagsak yung cardiac output, you can have a compensatory increase in systemic vascular resistance or peripheral resistance. Hence, your patient will have cold, clammy extremities. Pero, pagtingin mo dito sa vessels, elevated yung jugular venous pressure. Full kasi yung heart niya. Then, of course, characteristic features, yung chest pain niya, or you could hear a murmur, or yung heart failure. The management involves giving the fluids, inotropes, or vasopressors. And of course, treating whatever is causing injury to the heart. Next, what about hypovolemic shock? So for hypovolemic shock naman, this is when there's massive hemorrhage or fluid losses. So in general, nawalan ka ng fluid sa katawan. So since wala kang volume, walang laman yung heart, lahat ay low. So meron kang low pressures lahat sa heart. So you have low central venous pressure, low cardiac output, and very low pulmonary capillary wedge pressure. There is just a compensatory increase in systemic vascular resistance. So again, your patients will have cold, clammy extremities, but this time empty yung heart. So non-distended jugular veins. Plus, you'll have history na dumugo masyado yung patient, very dry yung mucosa, decreased yung skin turgor. So the management here is repletion. So you give fluids, blood, or hemostasis. Stop the bleeding if bleeding is the cause of hypovolemic shock. The last two are obstructive and distributive. So obstructive shock naman is another cause of decreased cardiac output, but it's because of extra cardiac causes. So for instance, in tamponade, there's impaired filling of the right ventricle. In tension pneumothorax, obstructed naman yung venous return into the heart. Yung pulmonary embolism, there's increased ventricular afterload. All of these will cause decrease in cardiac output. But because it's obstructed here in the heart, very pertinent here are the increased pressures, increased CVP from the back pressure. You may also have increased pulmonary capillary wedge pressures or the left atrial pressures and ventricular overload. And there will be a compensatory increase in systemic vascular resistance. So again, cold, clammy extremities pa din yung patient. Pero very elevated yung jugular venous pressure. So the treatment here is to treat the cause. So if you have tamponade, do the pericardiocentesis, remove the fluid. If you have the tension pneumothorax, remove the air with tube thoracostomy. If you have pulmoembo, melt the clot, so thrombolysis. And lastly, distributive. So siguro ito yung mas common sa atin. Distributive includes many types, the most common of which is septic shock. So septic shock involves nagkaroon ka ng dysregulated systemic inflammation. In anaphylaxis, you have so much exposure to allergens and there's massive extravasation in the vessels. And neurogenic shock naman is meron kang dysautonomia system-wide. So all of this are, ang pertinent here is babagsak yung systemic vascular resistance mo. The rest, you can have reduced CVP and pulmonary capillary wedge pressure and a compensatory increase naman in the cardiac output. So siya yung unique for having warm shock. So your patient will shock siya, hypotensive siya, pero very flush and warm yung skin. And then the treatment will be again targeted. So kung septic, antibiotics and SARS control. Kung anaphylaxis, IM, epinephrine. If it's neurogenic, then fluid resuscitation and supportive. Akit mo yung heart rate, atropine, ganun. So very unique ang distributive shock kasi it's warm shock. Okay, so this is just summarized in Harrison's. So let's look at the choices here. So which of the following is consistent with shock? Yung patient natin, nagkaroon siya ng ACS STEMI, tapos bumagsak yung ejection fraction. So it's not able to pump anymore because of the massive myocardial infarction. So your patient, the jugular venous pressure, correct, it should increase. Cardiac output will be decreased. There should be a compensatory increase in systemic vascular resistance. And again, because may increased systemic vascular resistance, meron kang cold, clammy skin. So, mali din to, cold, clammy skin. So the answer is A. Okay, let's move on to number 5. Okay, so it's a very long question, pero we can cut this down. Basically, you have a 78-year-old female, hypertensive, diabetic, meron siyang dyspnea. And on swab, positive siya for COVID. On the chest x-ray, meron siyang diffuse patchy opacities and infiltrates. However, sobrang nag-decline yung respiratory function and patient was intubated in the ICU. So in the ventilator settings, tidal volume 400, respiratory rate 25, positive end expiratory pressure is 18, FiO2 is 70%. On her ABG, pH is 7.28, PCO2 is 55.1, PO2 is 69.7, bicarb is 23.3. How would you classify her ARDS? Okay, so usually, I chose questions like this because in our IM exam, you only have a very short time, but then most of the questions are very long cases, and then you're given a number of questions. So the technique here is if you have a very long question, so that you know what to look for in the question, tingnan mo na kaagad yung tinatanong mismo. So the question here is, how would you classify her ARDS? So a while ago, we reviewed it, diba? The classification of ARDS involves computing for the PF ratio. In other words, you didn't have to read the question talaga. Ang hahanapin mo lang, ano ba yung components ng PF ratio, which is the PaO2. So yan, you can circle this one, the PaO2 and the FiO2. So these are all you needed from that very long question. So PF ratio is equal to, so everyone, we can divide it, no? 69.7 divided by 70% or 0.7. So what were you able to compute? We'll tell you with classification of your ARDS. Sige. The next question naman here, what demonstrated mortality benefit? We'll go through that later. So a little about ARDS. ARDS is the clinical syndrome of acute hypoxemia, reduced lung compliance, and then you have a lot of these infiltrates. So it's a very devastating syndrome, no? As reviewed a while ago, no? You're all familiar with the Berlin definition, which involves within a very acute history, 1 week history of bilateral opacities that are not explained by any cardiogenic cause. And then, as mentioned, the PF ratio, 300 below mild, 200 below moderate, 100 and below severe. Of course, this must be fulfilled, no, with patients receiving at least, no, 5 centimeters water of positive pressure. Yan. And the severity of ARDS correlates strongly with mortality. Kaya it's really important we know how severe the ARDS is. Share ko lang that recently there's a new global definition of ARDS, which incorporates some additional features. They included the use of high flow. So kung nakapag high flow nasal cannula ka na more than 30 liters per minute, as well as use of the CPAP with positive pressures more than 5 centimeters water, actually mild ARDS na daw yun. They also included another metric, the SpO2 over FiO2, as an alternative criterion to the PF ratio. And they also included here, dapat when the lung ultrasound was done by a trained professional, and you also saw bilateral infiltrates. So, but then what's pertinent lang to remember is that same pa din yung severity classification, 300, 200, and 100. And then the patients with ARDS undergo 3 pathologic stages in the first week, no? It's more on exudative, meaning may edema, interstitial edema. So nasisira kasi yung alveolar barrier to fluid, and so it leaks fluid out. There's edema na in your interstitial and alveolar spaces. The next is the proliferative stage, which is the day 7 to 21. So in here, here is nagkakaroon ka na ng proliferation of the T2 alveolar cells, nag-infiltrate na yung cells mo into the interstitium. This is also during the time that you will start having repair and the first signs of resolution. So, very rich in lymphocytes tayo. Usually, some people already recover during this stage. Yan, okay ka na. But there would be some unfortunate ones who will progress to the fibrotic stage. So, as mentioned by the name, they will have fibrosis. And then nag-obliterate, nasisira na yung normal lung architecture. So this is just a summary of what are the important guidelines for management. So very strong, very strong green. Strong recommendations include low tidal volume ventilation. So as mentioned, 4 to 6 ml per kilogram predicted body weight, and low pressures. So this has mortality benefit compared to conventional, no? And also prone positioning has been shown to have some reduction in mortality in severe ARDS. Some conditional recommendations, again, not so much evidence, but then pwede na, is the high PEEP strategy, which is you add pressure, you add positive pressure para hindi mag-collapse yung mga alveoli. So what about the against? In ARDS, we recommend against recruitment maneuvers. Yan. So do not do recruitment maneuvers kasi they actually can be found to have increased mortality pa nga, especially when you use it with increased PEEP. They also strongly recommend against high-frequency oscillatory ventilation kasi hindi siya beneficial. So yun na yung kailangan alahanin. Low volume, prone positioning, and maybe high PEEP strategy. Okay, so Here, when we computed, no, again, 69.7 divided by 0.7, actually, the answer here is 99.5. So yung patient mo is severe ARDS. And which of the following demonstrate mortality benefit? It's letter D, low tidal volume ventilation. Okay, next, number 7. A 66-year-old male, this one is a 50-pack-year smoker with progressive shortness of breath, chronic cough, yellowish sputum over the past 2 years. So, nag-spirometry studies tayo. The FEV1 over FVC is 65%. What's that? Less than 70, no? Mababa din yung FEV1. Tapos, nag-respond ba siya to bronchodilator? No, there's no significant response to bronchodilator. So, na-hospitalize na daw siya twice this year for exacerbation and given unrecalled antibiotics. His CBC shows hemoglobin 8, WBC 9,500 cells with 4% eosinophils. Which of the following is your preferred pharmacotherapy? Is it LAMA alone, combination LAMA and LABA, combination LAMA, LABA, and ICS, or theophylline? Okay, so a little about COPD lang, just a quick review. Again, this is a lung condition where there is chronic respiratory symptoms. So lahat nun pasok sa patient natin. Meron siyang dyspnea, cough, sputum, tsaka exacerbations. Unfortunately, this one is more progressive and persistent, and it causes airflow obstruction. So you can when do you suspect COPD? If your patient has a progressive dyspnea that is worse with exercise, ano pa ba? Mga chronic cough can be intermittent, not always productive ang cough ng COPD. Also, they have a history of recurrent respiratory tract infections and meron silang risk factor. So they can be smokers or na-expose sila sa smoke from heating fuels, yung nagluluto ng wood. And then meron silang chemical gases. Kaya meron silang work sa industrial smoke na exposed sila, chemicals. And other host factors can also be included. So how do we assess them? We have to do the spirometry. So in spirometry, it's mandatory to establish a diagnosis. You need to establish that the FEV1 over FVC is less than 0.7 and na hindi siya reversible by bronchodilator. Kasi persistent siya. So kahit anong amount of dilation you do, unfortunately, meron pa ding airflow obstruction. And then it's categorized. So based on the FEV1 itself, you can do gold 1, 2, 3, and 4. And the classes A, B to E, as mentioned, no, you can classify them by symptom severity as according to the questionnaires. But if you have any 2 moderate exacerbations or any one leading to hospitalization, it's already E automatically. Okay. So how do you treat them? On the use of bronchodilator, for COPD, which is a chronic condition, LABA and LAMA are preferred over their short-acting counterparts. And when you're trying to initiate treatment, the preferred choice is combination LAMA-LABA. Okay? What about anti-inflammatory agents? Kung sa asthma, ang sobrang patok doon is the ICS. Sa COPD, actually, hindi siya masyadong recommended. We do not encourage the LABA-ICS combinations in COPD unless meron lang tayong specific subpopulation that we give ICS additional treatment. So, some of these include medyo malalaking condition ng patient mo. May history na siya of hospitalization or hospitalizations for exacerbations of COPD. At least 2 moderate exacerbations siya of COPD a year. The blood eosinophil count is more than 300. And anyone with a history of asthma as well. So these are the subpopulation in COPD in which you would consider adding an ICS. So if there is an indication, then it has to be a combination LABA, LAMA plus ICS. And anyone who has COPD plus may features of asthma, you have to always contain an ICS. So in this case, so na-confirm natin na may COPD yung patient natin. Tapos, unfortunately, it's very severe, diba? So this year lang, twice na siya na hospitalized for exacerbation. And then let's compute the eosinophil count. So 9,500 4% of that is 380. So more than 300, no? Mataas yung ating eosinophil count. So because of this, pasok tayo sa recommendation for which we would prefer yan, LABA-LAMA plus ICS. Tapos yung theophylline, hindi yan safe. Hindi yan masyado first line. Okay? Next, number 8. So we have a 32-year-old female, known hypertensive with impaired fasting glucose. Ano pa? O, mga keywords. Central obesity with purplish striae. Patient has amenorrhea, facial hair and acne, as well as back pain. So for this one, what is immediately nag-ring in your brain? Yan, no, very characteristic, Cushing's. So dapat nagsuspect na kaagad kayo ng Cushing's. So they did some tests. Her midnight salivary cortisol levels are elevated. Her plasma ACTH is high, and her high-dose dexamethasone was able to suppress the cortisol. So what is the treatment of choice? So let's go a little to Cushing's syndrome. Cushing's syndrome is the constellation of features in which you just have chronic steroid exposure. Okay, so it can be caused by many things. Pwedeng your anterior pituitary gland produces so much ACTH, or you have an adrenal hyperproduction. So pwedeng hyperplasia or tumor mismo that overproduces cortisol mismo. Or you have exogenous exposure, yan, steroid abuser, ganun. Or there would be ectopic production of ACTH from cancers elsewhere in the body. So all of this will lead to the Cushing syndrome, which is featured by weight gain. You have a very flushed round face, high blood pressure, thinning of the bones, back pains, ganun. You have very thin skin, reduced muscle mass. You can have some depression or mood changes, and umaakit din yung blood sugar. So the causes can be classified into ACTH-dependent causes and ACTH-independent causes. So yung ACTH is, meaning nagkakaroon ka ng Cushing secondary to the overproduction of ACTH. Then the ACTH causes the adrenals to stimulate the cortisol. As opposed to ACTH-independent, in which sobrang taas ng cortisol as produced by the adrenal conditions, and then actually that will cause some negative feedback. Bababa naman yung ACTH. So these are some signs and symptoms. So as mentioned, we already talked about them. So ito, purplish striae with central obesity. Okay. So let's go through the algorithm. So when you have those features in a patient, you can now suspect Cushing. So to confirm it, there are 3 tests that you can do, no? First is exclude pala. Exclude exogenous glucocorticoid use. And then you may confirm Cushing's. So one is you can do 24-hour urinary cortisol. So in 24 hours, sobrang taas ng cortisol sa ihi. Other is dexamethasone overnight test. So in here, you have low doses of dexamethasone. You give it at midnight. And then, dapat kasi normally, if you give the dexamethasone, your plasma cortisol should normally be inhibited. But if it persists, mataas pa din siya, come morning, then it's Cushing's. Also, you have midnight salivary cortisol being high. Kasi dapat by nighttime, mababa na yung stress hormone level. Pero if at midnight, mataas pa yung salivary cortisol, then you probably have Cushing's. Okay, so the next step is to acquire the plasma ACTH. Kasi if you already know you have Cushing syndrome, is it ACTH dependent or not? ACTH independent? So again, if the Cushing's is due to a pituitary or an ectopic tumor that's producing the ACTH, o then magkakaroon ka ng mataas na ACTH. However, if your Cushing's is from the adrenal glands, they're producing the cortisol mismo, there will be negative feedback and masusuppress yung ACTH. So, mababa yung ACTH. So, dito naman na tayo sa suppressed. If suppressing ACTH, then let's look for the lesion in the adrenal. So, the next thing to do would be adrenal CT scan. And then if it's unilateral, you can remove just the one adrenal. If it's bilateral, you can consider removing both the adrenals to solve the problem. On the other side naman, if it's the ACTH that's causing the Cushing's, let's differentiate what's producing it. Is it from the pituitary or from the ectopic tumor? So for this, actually, you may do a pituitary MRI, but there are cases kasi that you won't see the lesion, masyado siyang maliit. So there are two hormonal tests you can do, which is the CRH test, in which you give the corticotrophic releasing hormone, and then the pituitary ACTH will increase, or a high-dose dexamethasone test. So if your patient has pituitary Cushing's, in other words, Cushing's disease, it still acts like a normal organ. In other words, the high-dose dexamethasone can still suppress it, and giving CRH will stimulate it. So yun, pag positive yung CRH, na-stimulate siya, pero tapos na-inhibit naman siya ng high-dose dexa, then your goal is to look for the lesion in the pituitary. Then you can do a transsphenoidal pituitary surgery. On the other hand, if it doesn't respond in the physiologic way, then probably it's an ectopic ACTH. So the treatment here is to hanapin natin yung ectopic ACTH tissue and remove it. So in our patient, let's go back, no? Nagsuspect na tayo ng Cushing's because of the physical features. Her midnight salivary cortisol, like we said, sa gabi dapat mababa pero mataas. So yun, na-confirm natin, sige, mukhang may Cushing's syndrome yung patient. So they took the plasma ACTH. The plasma ACTH is high, meaning you have something that's overproducing the plasma ACTH. Was it able to be inhibited by DEXA or stimulated by CRH? Mukhang na-inhibit siya properly ng DEXA. Therefore, we suspect that it's Cushing's disease or a pituitary ACTH hyperproduction. So what's the treatment of choice? It's transsphenoidal pituitary surgery. Okay. Next, number 9. Okay, GI question. A 45-year-old male consulted for one-day history of passage of black stool, tapos meron pa siyang lightheadedness. He has noted recent worsening of a chronic epigastric burning pain, which has been a problem for years. So he tried to elicit bakit kaya. On history, he takes NSAIDs pala weekly for back pain, and he smokes during his breaks with his colleagues. On upper endoscopy, we saw a flat pigmented spot in the gastric mucosa. So which of the following is the appropriate management? Do we do endoscopic therapy, intensive PPI, then hospitalized for 3 days? Once daily PPI, hospitalized for 1 to 2 days? Once daily PPI, discharge kagad? Or endoscopic ligation, IV octreotide, and then hospitalized for 3 to 5 days with clear liquids? Okay, so this would be a very good slide to review for upper GI bleeding. It summarizes our approach to upper GI bleeding. So when you have a patient with upper GI bleeding, by the way, why is it upper GI bleeding? Kasi black, mga ganun, black tarry stools. Upper GI yun kasi mataas yung source of the bleeding. After niya dumaan ng GIT tract, naluto na siya, kaya black na siya. So, if you have an upper GI bleeding, you have to stabilize your patient muna, no? Once stable, you can do the upper endoscopy. How soon? You can perform it within 24 hours in most patients, pero if high risk yung patient mo, let's do it urgently within 12 hours, no? And then ito, ano yung nakita sa endoscopy? So that will determine your next step of management. So this, depending on the endoscopic diagnosis, you might be able to see an ulcer, varices, a Mallory-Weiss tear, pwede ding some erosions. So in general, if you find an ulcer, which is more consistent with our patient, kasi NSAID user, you can manage the patient with some combination of either endoscopic therapy and PPIs. However, if it's varices, the management involves more on endoscopic ligation and octreotide. So, pag may varices kasi kailangan i-ligate, rubber band ligation ng varices dito sa esophagus, ganun. And then you have to give a vasoactive drug like octreotide. Mallory-Weiss tear, this one is more on yung mga nag-retch, ganun yung history nila. You may give them endoscopic therapy and or antiemetics, so para to stop the retching and the damage. And then for erosions, no, just PPI. So let's do a closer look on the ulcers. So depende, you can have a visible vessel or active bleeding. These ones require endoscopic therapy, intensive PPIs, and then you have to hospitalize for 3 days. Yung adherent clot, no, plus minus endoscopic therapy, Pero still, you do intensive PPI therapies and you also hospitalize for 3 days. As opposed to the others. So, kung flat pigmented spot lang siya, you don't need endoscopy. You can just do once daily PPI therapy and then just observe for 1 to 2 days before discharge. Pag clean base, wala kang indication, you can discharge na kaagad after the endoscopy. Just give the once daily PPI therapy. So for our patient, meron siyang flat pigmented spot. The answer for that patient is no endoscopic therapy necessary. Just do the once daily PPI and hospitalize for 1 to 2 days. A little lang about lower GI bleeding. So, pag may lower GI bleeding ka and hemodynamically unstable yung patient, baka you have to rule out massive upper GI bleed so you can do the upper endoscopy. But after that, as in also patients na no hemodynamic instability, dito ka talaga bababa, no? Colonoscopy. So, you will need a colonoscopy after oral lavage to see the cause of the lower GI bleeding. Okay? So for this patient, the answer is B. Once daily PPI, then just hospitalize to observe for 1 to 2 days. Okay, last question. A 60-year-old female is referred to you for anemia. She had previous history of gastrectomy. On examination, she has deficiency in proprioception in lower extremities, has wide-based gait, positive for Romberg sign. Which of the following deficiencies is most likely the cause of her symptoms? Okay, so a little about the approach to anemias. Among the anemias, you can have iron deficiency, which can cause either a normo-normo or a microhypochromic anemia, as opposed to the folate and the vitamin B12, which causes macrocytic anemia. So for the iron deficiency anemia, it can be due to chronic bleeding. For instance, minsan may cancer doon, tas it bleeds, pwede rin due to malnutrition, as well as increased demand, such as in pregnancy states. So on lab exams, you have very low stores, yun yung low ferritin. You have low iron and high TIBC. So TIBC, para siyang taxi para sa iron. So kung kulang yung iron, marami kang available na taxi para sumakay. And then, your patient can present with fatigue and conjunctival pallor. So yan, may pallor yung patient. And on RBCs, you have here, maliliit yan, microcytic and hypochromic anemia. So this is already pag severe na yung iron deficiency anemia. So malaki yung central clearing, yan yung hypochromic. Another is Plummer-Vinson syndrome. So baka matanong to, iron deficiency anemia can manifest as Plummer-Vinson syndrome. It's a triad of iron deficiency anemia, esophageal webs here. So you have some webs in the esophagus causing some dysphagia symptoms, and atrophic glossitis. There. What about folate and vitamin B12? So these ones naman, as opposed to the iron deficiency, will cause a macrocytic anemia. That's because those two nutrients are very important for nucleic acid synthesis, for creating the nucleus of the RBC. So it's really important though to identify which vitamin is deficient. One way to do so is the biochemistry test. So for methionine synthesis, to produce methionine from homocysteine, it requires both. You need both folate and vitamin B12. But, so if either is deficient, aakyat yung homocysteine mo kasi you cannot produce the methionine. What about the conversion of methyl malonyl coenzyme A to succinyl coenzyme A? It requires vitamin B12. So in vitamin B12 deficiency, there will also be increase in methylmalonic acid CoA levels. Pero this reaction is unperturbed in folic acid deficiency. So in folic acid deficiency, it can be caused by malnutrition, so mga chronic alcoholics, malabsorption, you're taking inhibitory drugs like methotrexate, or you have increased requirement like in pregnancy states, as well as hemolytic anemias, ganun. On your labs, as mentioned, ang aakyat lang dito is yung homocysteine mo, pero normal yung methylmalonic acid. And your patient doesn't really have neurologic symptoms. You'll be able to see here macrocytosis of erythrocytes and You can also see hypersegmented neutrophils. Now, what about B12? Vitamin B12 deficiency can be caused by insufficient intake. For instance, mga hardcore vegans, malabsorption, like nagkaroon ka na ng gastrectomy, or Crohn's disease. You have a tapeworm in your GIT. So the Diphyllobothrium latum fish tapeworm competes with you kasi to absorb the vitamin B12. Pernicious anemia as well. The body is unable to absorb vitamin B12. In your labs, aakyat yung homocysteine and increase din ang methylmalonic acid. Plus, pertinent here is that meron kang neurologic symptoms. So usually the neurologic symptoms is a subacute combined degeneration. Why? Because vitamin B12 is also important in the myelin synthesis. So kung nasira yung myelin production, you'll have problems in proprioception, memory problems. Yun. So it's very important to identify vitamin B12 deficiency because kunyari vitamin B12 deficiency pala siya tapos folate lang yung binigay mo, baka irreversible na itong neurologic damage. So for this question, the answer is vitamin B12. However, I will also accept intrinsic factor because nag-gastrectomy yung patient. So what I forgot to mention a while ago is that for us to be able to properly absorb vitamin B12, no, kailangan ng intrinsic factor, and that's produced by the parietal cells of the stomach. So for those who are very keen, nag-gastrectomy yung patient, tapos may signs of vitamin B12 deficiency, intrinsic factor is also considered an answer. Okay, so that's the last of my questions. I just want to share, malapit na pala yung board exams. So if you feel yourself hitting up against your limit, remember always why you started down this path and let that memory carry you beyond your limit. So always go back to why you're doing this. It's always for your patients. So that should inspire us to continue hitting the books. And I really wish you all the best for the upcoming board exams. Thank you.
Okay, thank you very much once again, CTIF. My favorite econ. No, wait. No, my favorite econ is supposed to be my girl. So hi. Hi, Doc. Thank you for that very inspiring message. Thank you for joining us tonight. Do you have any questions for Doc Tiff? I don't see any here tonight, and let's not take too much of her time. She's a busy resident of St. Luke's. Thank you very much for joining us. Guys, I'm going to see you guys tomorrow. I know I owe you the dinner club contest. I'm going to see you guys tomorrow after the introduction to Pedia. Okay, so thank you very much for joining us tonight. Thank you, Doc Tiff. Thank you, Doc.
For having me. Thank you.
Thank you, Doc Broly. Thank you, Doc Ian. Thank you, everybody. The MGs, guys, I sent a reminder in our Viber groups. Kung nakikita niyo yung messages ko sa Viber groups, please put a heart on it. If you don't, if you have messages that I have not answered, please please bump it up na lang para ma-address natin, no? Final reminder lang, if you are going to have clarifications with Dr. Banzuela, when you send him your questions regarding your academic questions in his personal Facebook page, please don't forget the relevant screen caps. And para hindi na siya maghanap, no? He can point it out and then send it na lang to whomever will answer the question. All right, guys, good night. Thank you. We've taken so much of your time. We hope you learned something. We will see you tomorrow. I'll see you guys tomorrow. Just wait for the Zoom link in our Viber groups. Good night. Bye, guys. At play tayo ng isa.